We all settle down. Please grab a seat. On behalf of the Federal Ministry of Health and Social Welfare, I'd like to welcome all of us here today. I can see that because of the importance that we attach to non-communicable disease or diseases, I usually would term it an added burden on the health sector. I'm sure that's why we're all so gathered here today with the seriousness to strengthening multisectoral collaboration. There is a tweak on the program, so we're going to start first with the technical session, which I can assure you would be the eye-opener for the other programs that have been so slated for today. I'd like to welcome you all to this launch of NCDC documents, Revitalizing NCDs Prevention and Control in Nigeria. It is imperative, if we are serious about improving the health sector output, to ensure that our outcomes, to ensure that we speak to NCDCs in Nigeria. We would continue to educate ourselves on how best we can put this, well, at least contain the high rate of mortality associated with non-communicable diseases in Nigeria. From all the states, I'd like to welcome you who are here. All our partners, I think before we start anything, they deserve a very loud round of applause, putting this together and ensuring that together we'll drive this program today. I said there's a tweak, so we'll start with the technical session, and then we'll do all the ceremonials later. And so I'd like at this point to, if you have your program, to start on page 5. Page 5 is where we're going to start. And the panel discussion 2 will kick this off. The topic is interventions addressing non-communicable diseases, risk factors in Nigeria. Moderator is ready. Any moment from now, please can we put on his profile? And I'd like to introduce Professor Augustine Odili. He's Professor of Cardiovascular Medicine, Consultant Cardiologist, University of Abuja Teaching Hospital. Can we please put our hands together as I bring him to the microphone? And I think it's the best place to start. Since he's a cardiologist, our hearts can be said to be safe considerably. And if we have any problem with that, we have this professor of cardiologist who would at least be able to give us a first aid. I do hope that our hearts will keep beating appropriately, but most importantly, beating healthily. So put our hands together for Professor Odili, who will now announce members of his panel. Please let the applause continue. Let's see how his heart is beating. All right, thank you very much. I'll hand over the microphone to him. A very blessed day. My name is Mujima Konchola, and I'll be your anchor for this event today. Right. Okay.
Thank you very much, our own Mujima Konchola, who has become a major partner when it comes to not just non-communicable diseases, but everything health in the country. Good morning, ladies and gentlemen. It gives me great pleasure to welcome all of us from all parts of our country and beyond to this great event. We will be starting with the second plenary session, and I would want to call, my colleagues who will be discussing with me here this morning. May I invite Dr. Pinda Wakawa, the WHO Country Office Global Strategies to Address Risk Factors. Please, can you please come up here? Can we put our hands together for him? May I also invite Betet Musa of Resolve to Save Lives to please come up to the stage. May I invite Dr. Malau M. Tuma, our own Dr. Malau. Please, can you come up to the stage? Professor Akin Osibogun, the Executive Director, NCD Alliance Nigeria. Please, sir, would you come up here to the stage? May I also invite my own colleague who is working with me at the University of Abuja Teaching Hospital and the University of Abuja, the Cardiovascular Research Unit, Dr. Dike Oji. Would you kindly come up to the stage? And may I also invite Mrs. Edda Edwards. I think one person, one of us is joining us online. So I think I have everybody here present to start off this discussions. Thank you very much. Sorry, please. The WHO, I think I gave the wrong name. WHO is the father and mother of all of us. So maybe I called the mother, and now I'll call the father. It's Dr. William Minor, who is representing the WHO in this meeting. So please, I beg your pardon for that. So may I request that we will kick off immediately. I'm going to start with WHO without wasting much time to find out what are we doing in the area of targeting non-communicable diseases, interventions to address non-communicable diseases risk factors in Nigeria. So, what role has international agreements, for example, the WHO framework, played in advising non-communicable diseases risk factors? Dr. Minor, thank you.
Thank you so much, moderator, and good morning, colleagues. Indeed, WHO has presided over the adoption of various strategies and frameworks to address non-communicable diseases, particularly targeting the risk factors. And I'm going to focus on the role of the WHO Framework Convention on Tobacco Control, which is an international public health treaty that was adopted by the World Health Assembly in 2003 and later on entered into force in 2005. Indeed, currently 183 out of the probable 194 member states of the World Health Organization have actually ratified this treaty. And this treaty provides governments or parties with a framework which has evidence-based strategies that, if applied at the country level, are going to contribute to the reduction of the prevalence of tobacco consumption, to considerable levels that are of no public health consequences. And this treaty provides very broad strategies. Firstly, it provides strategies for reducing the demand for tobacco products. It also provides strategies for reducing the supply. And these strategies applied together are going to reduce tobacco consumption over a period of time. In the Africa region, we have, in the WHO Africa region, we have 47 countries. And out of these 47 countries, 43 of them have actually ratified this treaty, and 40 of them have actually domesticated this treaty in national laws. Nigeria is one of these countries, and this country domesticated the FCTC through the implementation of the Tobacco Control Act 2015. So WHO, its work is to provide normative guidance and technical support to countries to actually adopt and implement global strategies and frameworks for the prevention and control of non-communicable diseases. What we do is to provide technical support in terms of technical guidance. We also provide technical assistance in terms of adoption and dissemination of those strategies, as well as programmatic setting for the implementation of all the provisions that are in these strategies. We also support the monitoring of the progress of these strategies, the implementation, as well as measuring the impacts of applying these strategies. And finally, we do support the sharing of best practices, and therefore we interact with other regions of the world, other countries outside Africa, in order to try and bring best practices and knowledge into our region. So this is how we interact. And for us to do this, then we have come up with the packages within these frameworks. And for example, to address tobacco control, we have what we call the Empower package. To address alcohol, we have also a package for alcohol. To address salt and dietary issues, we have a package for that. And also to address the issues of physical inactivity, we have a technical package. And these packages are best practices that we call best buys, that if applied in developing countries at any country, we will be able to considerably reduce the NCD risk factors so that we reduce the burden of non-communicable diseases in our region and globally. Thank you.
Thank you very much. Please, can we put our hands together for WHO? I have been a beneficiary of WHO packages. When I realized that WHO has packaged everything for anybody who wants to do anything in non-communicable disease, in fact, in all areas. In fact, I always tell my colleagues that all you need is go to WHO website. You see what you need. So WHO, we sincerely appreciate your efforts. And I know that some of these packages have been utilized globally. And in one way or the other, these global issues have also affected us. To discuss some of these packages that have been used globally, I would want to call up the Resolve to Save Lives. However, before he comes up, there are a few of our colleagues who are supposed to be in this panel. I mixed them. Please permit me to welcome Mr. Chibike Nwokorie. He's the program officer of Nigeria Tobacco Control Alliance. Please, Mr. Okorie, can you come up? May I also invite the Corporate Accountability and Public Participation Africa, that's CAPA. The executive director is here in the person of Akim Bode Oluwafemi. Please, can you come up? So I think the house is full now. So we are going to have a full package of the event. So Resolve to Save Lives. WHO has really introduced frameworks and packages that have been able to help in different aspects of non-communicable diseases. Would you kindly throw more light on some of those packages that have been deployed by Resolve to Save Lives globally, and maybe with particular reference to Nigeria. Resolve to save life, please.
Okay. Good morning, everyone. Thank you for the question. So, just like WHO has mentioned, salt reduction, it's one of the core strategies that we have, to address the intake of unhealthy diets. And for us, we've seen that a lot of countries have adopted salt reduction as a critical approach to ensure that the intake of sodium, excess sodium, is reduced. And we know that the intake of excess sodium has been linked with increase in high blood pressure, strokes, which are all risk factors to cardiovascular diseases. And in addressing this, a focus has been given to looking at the sources of sodium. We have addressing packaged foods, and there are different interventions in addressing sources of sodium in terms of packaged foods, looking at setting mandatory salt targets. We have the front of pack labeling, as well as market restrictions. And also addressing the sources of sodium coming outside the home. There are policies, for example, coming up with healthy public food procurement policies to ensure that we consume or we purchase foods that are rich and not foods that are high in unhealthy nutrients. We also have foods that we consume from home. And one particular intervention that works in addressing this is through mass media campaigns, which on its own, it's not as effective standing alone, but it's mostly paired with other interventions that I have mentioned. And for us at Resolve to Save Lives, we have been working to support governments around the world, including Nigeria, to come up with best practice policies that will address the issue of sodium reduction. I'm just going to provide an example for us to see other countries that have done some work that have helped and have yielded some results. And I'm going to start close from home here in South Africa. In 2013, the South African government set up policies, mandatory salt target policies that aims to set up limits for sodium in their food packages. Food categories, we have about 13 food categories that had that. And we've noticed that between 2015 and 2019, in the space of 5 years, they've witnessed about 25% reduction in the intake of sodium. And even in UK, where they also they were able to set up mandatory salt targets, they were also able to witness between 2003, when they started, and 2014, a 19% increase. And they've even gone further to have some impact studies that showed clearly that this led to a reduction in the incidence of strokes and other conditions that predisposes one to cardiovascular health diseases. So for us, like you said, in Nigeria, we're also working in partnership with the Federal Ministry of Health to also see that Nigeria is also able to adopt some of these best practices as recommended by the WHO to see that we also have a healthy nation. Thank you.
Thank you very much, Resolve to Save Lives. I'm sure, members of the audience, you are getting your questions or comments. We have worked with Resolve to Save Lives all this while. in the projects in non-communicable diseases control. Incidentally, he talked so much about salt without mentioning some of the numerous things Resolve to Save Lives is also doing in hypertension control, production of simple protocol all around the world. And I remember when we went to Japan in the International Society of Hypertension, the simple protocol that was deployed even in India has been very effective in reduction and control of hypertension. So, ladies and gentlemen, may we put our hands together for Resolve to Save Lives for that. Now, moving forward, at the starting point of this discourse, he mentioned that they work with governments, Federal Ministry of Health in different countries. It may be important to share experiences from our own Federal Ministry of Health and the NCD division. And no other person will do that better than Dr. Malau, who is the head of the cardiovascular and tobacco control of the Federal Ministry of Health and Social Welfare. It will be interesting to find out what are the most effective policies and legislative actions to reduce non-communicable disease factors that your unit has been able to implement in the past couple of years. Dr. Malau.
Yeah, thank you, moderator, Professor Austin Odili. Distinguished ladies and gentlemen, having heard from the global perspective down to the regional perspective, we need to trickle it down home now. Based on the global baselines, which Dr. William Miner has explained from the WHO perspective, and to my colleague from Resolve to Save Life has also spoken. So from Federal Ministry of Health, we have looked at all the global documents, which of course, Nigeria is a member of the WHO. In the WHO, there are a lot of treaties and other conventions which Nigeria signed and ratified. So within this milieu, we have looked at our own local context and have seen and documented the challenges we are having. And the best way to deal with this is to adapt most of the global documents targeted to non-communicable disease prevention and control. So foremost, the Federal Ministry of Health and Social Welfare led stakeholders to produce the national policy for the prevention and control of non-communicable disease. The policy is very comprehensive. It looked at the totality of all the risk factors driving non-communicable disease. And beyond that, we have also looked at those risk factors that may not necessarily be easy for us to change or to modify. The policy also addressed such. And within the large framework of that policy, we have further gotten standalone policies that can address distinct risk factors. Like addressing tobacco, we have the National Tobacco Control Strategic Plan of Action. We have National Tobacco Control Communication Strategy. And we also have the National Tobacco Control Act 2015, National Tobacco Control Regulation 2019, and we have also produced National Tobacco Control Enforcement Plan. And these documents are evidence-based, and we have looked at the best by. So beyond that, we also have policies that will address harmful consumption of alcohol. taking into account those best buys too. And we also have policies that will produce or help us to have a very good environment that is free of pollutants, which are very harmful, and they are leading risk factors for chronic respiratory diseases. And we also have policies that will help us address unhealthy diets. Because just as how it was mentioned, within the unhealthy diet, salt is one aspect. Then unhealthy consumption of other components of the foods that people usually eat, like high fats intake. Prominently, the one that is very toxic to the cardiovascular health is trans fatty acids. So we have looked at it, and we have that one entrenched in our regulations for fats and oil to limit fats intake in our transition to total elimination of industrially produced trans fat. And within that framework, we have also embedded in these documents what can help us achieve successes. For instance, if we are able to implement weighty taxes, it will greatly reduce the consumption of some of these unhealthy foods items. And we have also looked at the components of public awareness creation. And beyond awareness creation, we've also looked at the component of training and capacity building to help people make informed choices. And lest I forget, all these ones I have said are tied together as unhealthy lifestyle. And whether we like it or not, the population is aging. And as the population is aging, almost all of us run the risk of coming down with one or two non-communicable diseases. So we must begin to address these risk factors squarely. And the other hereditary component that I think I need to mention is the sickle cell threat. So we need to create, and we have a framework that is educating families, educating the community to make informed choices when it comes to selection of spouses. It's very important so that we can reduce the transmission and the prevalence of some of these hereditary risk factors. Thank you.
Thank you very much, Dr. Mala. Please, may we put our hands together for the Federal Ministry of Health and Social Welfare for the work they are doing in the area of policy, laws, and regulation for a healthier society, Nigerian society. I know that I have worked with this unit over the years, and one of the things they will always emphasize is partnership. And you cannot have partnership without really finding stakeholders and those who are involved in NCD space. The NCD Alliance Nigeria, whose executive director is a foremost public health physician in this country, Professor Akin Usibogun, is ably represented by Dr. Akiwumi Adebowale, and who is seated to my immediate left or right? Left, yes. So, you know, the heart is on the left, so you want to avoid it anyhow when you are talking. So, he will be telling us the structural and individual level instruments and at the home, leisure, and job spaces that NCD Alliance, through their different partners, have been able to put together in a fight against non-communicable diseases. Thank you.
Thank you. Good morning, co-panelists. Thank you very much for having me. NCD Alliance is a network of the global NCD Alliance, and they've been active in promoting non-communicable disease control and prevention across the group. And the network in Nigeria is a very active member of that network. And over the years, the NCD Alliance have been involved in serious efforts in making, contributing to the control and prevention of non-communicable disease in Nigeria, and looking at the various risk factors that have been mentioned. One of them, which has not been mentioned thus far, is the physical inactivity, which little or nothing is being done about it by the national players. A lot is being done about tobacco control. A lot is being done about salt reduction and working with the food industries to reduce salt consumption and sodium consumption. However, for the physical inactivity, a lot has to be done in order to address these major risk factors for non-communicable disease. NCD Alliance has been proactive in working with relevant partners and Federal Ministry of Health in ensuring that at workplaces and at schools, we have recreation facilities to promote active exercise and physical activity across the set setting. A coordinated and a collaborative approach is very important, is necessary in ensuring that people are active and they reduce the burden of these risk factors in Nigeria. About 50% of Nigerian adults have been found out to be inactive over the years, and this is huge. And also, looking among the adolescents, that figure is also worrisome, in which about 80% of our adolescents, these are school-age children from 10 to 19, who have been found out not to be physically active. And those that are not physically active have been found out to be about 20 to 30% higher risk of dying than those who are physically active. So NCD Alliance Nigeria, and with within the framework of the global network, have been active in promoting physical activity and exercises among the populace. And recently we're going to launch the newsletter, People Living with an NCD newsletter today. This is also one of the activities that the network, the NCD Alliance, is also doing, promoting communication awareness about these various risk factors across the level, in the community level, and working with other community-based organizations to promote awareness about risk factors for non-communicable disease and measures that are needed to be taken in order to address it, both at the population and at the individual level. Exercise for about 30 to 60 minutes most days of the week, about 4 to 5 days of the week, have been found to be very useful and helpful in reducing physical activity and sedentary lifestyle. Thank you very much.
Thank you very much, NCD Alliance, for bringing out a very important aspect of non-communicable diseases, which is physical inactivity. We cannot do all this without research and data. And it gives me great pleasure to invite my colleague, who incidentally works in the same unit with me, to talk about research, data generation in the area of sodium. I mean, if you want data in many areas of non-communicable diseases nationwide, there's no better place to go to than the cardiovascular unit of University of Abuja. Can we put our hands together for the unit? And on that note, I want to call on Dr. Dikeoji of University of Abuja to tell us the key findings of the sodium consumption study in Nigeria. Dr. Dikeoji, over to you.
Thank you very much, Professor Tilly, and good morning to everyone. Maybe I will just start off by saying that you cannot drive policy without good data. And the only way you can have good data is good research. And good research takes time, takes resources, takes a lot of money. And I will also say that one of the good things happening in the NCD world in Nigeria is the fact that we are now having data that we can boast of, data that we can go to anywhere and present. And that is one of the very, very good things that has been happening. So I want to appreciate the NCD division of the Federal Ministry of Health, for all the partnership and driving this. And then down to sodium. We know that excess sodium is what the problem is. We need sodium. Every one of us needs sodium. We know sodium chloride for normal hemodynamic activities of the body. But when it is excessive, then it becomes a problem. And why does it become a problem? Because it drives high blood pressure. High blood pressure is the #1 risk factor for cardiovascular disease all over the world. It's the main risk factor or #1 risk factor for death all over the world today. Through stroke, through chronic kidney disease, through heart failure, and through heart attack. So if you take care of high blood pressure, you take care of most of the cardiovascular diseases we have in our country today. So what is the relationship between excessive salt then and cardiovascular disease through the route of high blood pressure? So what are we trying to do in the Nigerian sodium study, which is led by the Cardiovascular Research Unit of University of Abuja? What we are trying to do is to create data that will enable the Federal Ministry of Health with other partners have tangible policy that will drive salt reduction in our country. But for you to even do that, you have to first of all know the level of salt we have in our country. So our first research has been around population survey. We want to look at in population, how much salt do our people consume? Number 2, how much salt is in our food? And number 3, the salt that our people consume, where do they come from most? Do they come from salt added at the table? Do they come from salt added when people cook? Or do they come from salt that we consume when we buy food on the street? So those are some of the things we have been trying to do. Our research has been in 3 parts. One of them is engaging different stakeholders, people like you, both physicians, practitioners, non-practitioner, government organization. We've done focus group discussion, in-depth interview with them for us to understand what they even think about salt in the first place. Then the second thing we've done is to do what we call retail survey, whereby we go to shops, big shops and smaller shops, retail shops, and we capture front or back labeling, using our phones, and those pictures or data are then transferred into a database in the George Institute, University of New South Wales in Australia. We are partnering with them. They are one of the greatest centers you can think of on salt. Then the third aspect actually is on population, whereby we have gone to the community. And one of the things we did in the community is to do what we call dietary recall. Dietary recall is one of the ways you can assess the amount of sodium people are taking. So we are working with nutritionists led by Mrs. Clementine Okoro. Then secondly, we are doing 24-hour urinary excretion of sodium, because it is said that what you excrete is proportionate, to what you take in. So what have we found? We have found that on the average, Nigerians consume about 3.8 milligrams of sodium every day, on the average. Men consume more sodium compared to women. And that is worrisome, because the WHO benchmark is 2.5 milligrams of sodium chloride. So that is quite high. That is getting to about 2/3 higher than what we are supposed to consume. The other thing we found out is where the sodium, most of the sodium comes from. It comes from sodium we add when we cook in our homes. That's one way. Secondly, a lot of sodium comes from bouillon, what people call Maggi and the rest, and those comes from about 25% of that comes from bouillon. Now, things like yaji, salt added at the table, about 9.1% of our sodium comes from that. Then another 5.1% comes from food that people consume on the street. So the message is that we are adding a lot of sodium to our food. We have to reduce it, because if we don't reduce it, then the trend in increase in prevalence of high blood pressure will continue. Then the other message is the bouillon we use, we have to reduce them. Either we reduce them, or secondly, the other thing is, if you add bouillon, why do you need to add salt again? Because bouillon already contains the salt. Then the other issue we can is it can be quite difficult to change people's behavior. So one of the things we should be looking at is looking at what we call salt substitute, whereby some of the sodium in the salt we take is replaced by potassium. Potassium has the advantage of reducing blood pressure, just like sodium increases blood pressure. We get a lot of potassium naturally from our food, but that might not be enough. So we might have to replace. Start thinking of salt substitute. That is one of the things we can do. And the good thing about some of the data we are generating is already leading to policy. We talked about front of pack label policy, you know, that was from our retail survey. Then there is a committee already on mandatory salt limit. Our data also is driving that. So we are in for good times, you know, as regards having data generating policy that will reduce salt in our country. Thank you very much.
Thank you very much, Dr. Oji, for enlightening us, especially in the area of research, generating data. One thing caught my attention. Research requires funding. And in this room today, it's important that we emphasize the need for concerted effort to raise more funding in the area of research. It was about 6-7 years ago that through the TED Fund National Research Funding, that I led the national survey in hypertension. And that data is what is subsisting up to today. Very soon, the Federal Ministry of Health-led survey result may be published. So we need money. And the competence to do the research work is there. And we continue to grow, capabilities. We continue to grow interest in research. So thank you very much, Dr. Oji, for the work you are doing. And we continue to ask that this kind of research that should stimulate and inform policy is what we should encourage in our country. Quickly, the Program Officer of Nigeria Tobacco Control Alliance, it's important to talk about the most significant challenges facing tobacco control efforts in Nigeria. I mean, looking at your work, what you have done, the efforts you have put in so far, would you, share with us the challenges that you have been able to, faced all this while?
All right. Thank you, moderator. Thank you, the co-panelists. I'll start by saying that all other risk factors mentioned here, our body need them at a little rate. But tobacco, we don't need it at all. I've not seen any doctor that will tell you when you are sick, take a stick of cigarettes. But somebody can go to a hospital, they will say he lacks sugar. Give him little sugar. But I've not seen any person. So that means this is a very serious area. And tobacco is a risk factor to virtually all NCDs. All of them, tobacco is a risk factor. Then, talking about NTCA, is an alliance of professionals, health professionals, individuals, organizations that are working on tobacco control and public health. And this alliance has really worked greatly, especially during the passage of the Nigerian Tobacco Control Act of 2015 and its regulation of 2019. And one of the greatest challenges advocating for this, one, most government MDAs have not seen tobacco control as their thing. Lack of ownership among government MDAs. Most MDAs see tobacco control as Ministry of Health versus us. It's Ministry of Health wahala. I remember in 2014, 2015, Thank God the chairman of our board is among this panel. When we are talking about the Tobacco Control Act at the National Assembly, an assistant director from one of government agencies was seriously opposing the act, telling the National Assembly people at the public hearing that Nigeria needs money, Nigeria needs this. Until then, Chairman Senate Committee on Health, the immediate past governor of Delta State, then Senator Ifeanyi Okowa, asked him, do you know that this act is an executive bill? He said yes. And being an executive bill means that your minister was seated at FEC when this bill was approved, before it was sent. It now dawned on the AD. So he asked him, are you now sitting here to oppose your minister? The man did not speak again until we left that public hearing. So that is what we get every time. Now, another big masquerade in tobacco control is the industry. The tobacco industry will come with a lot of fake statistics, telling us how Nigeria is making billions, trillions. And when they sell all these things to many government agencies, individuals, they come by also doing a lot of CSR. So even the people you are talking about, they will see you as an enemy. That these people are building this for us, are doing this for us. Why what governments and WHO has recommended is that let them pay their tax. Allow government to use their tax to do the needful. But they will come by way of doing CSR, and when they do those CSR, they use it to louder their image. So until government MDs, until government agencies, they see tobacco control as Nigerian health policy, not Federal Ministry of Health policy, because that is what we are seeing now. You go to a government NDA to talk about tobacco control, they will now quote another thing just to tell you that, we are signatory to this, we are signatory to that. But we are forgetting that a healthy nation is a wealthy nation. If Nigerians are not healthy, all the fake indices, economic importance that the industry is pushing out, they are not to the betterment of all of us. So we are using this medium to call all of us to see the issue of tobacco control as a Nigerian issue, not Federal Ministry of Health issue. I'm not going deeper to say a lot of other things about tobacco. So until we see tobacco control as a Nigerian issue, we will not make the effective headway. Thank you.
Thank you very much. Enemy or enemies within, enemies without. Battling tobacco control. I would call on another person, the Corporate Accountability and Public Participation Africa, to tell us about sugar-sweetened beverages. And I carefully left you to talk last because I was waiting for Professor Anoma to come into the hall so that she will listen to you while talking about sugar-sweetened beverages. Professor Anoma is also passionate too about sugar-sweetened beverages, and she has just walked in. So I wanted you to talk while, she's here. So, Akibode of Kappa, would you want to tell us what are the key gains to implementing and enforcing sugar-sweetened beverages taxation in Nigeria? Over to you.
Thank you very much, moderator. First, let us understand what we mean when we say sugar-sweetened beverages. They are concentrates, either powdery form, drinks that are non-alcoholic but have in them added sugar. The simple description we give to them in Nigeria is soft drink. When we say soft drink, I think we all know what they are. The issue is that as of today, Nigeria is the fourth largest consumer of SSBs in the world. And SSB is a major risk factor in type 2 diabetes. Now, governments around the world, UK, Poland, South Africa, several other governments in the world, have realized that we need to cut overconsumption of SSBs as part of intervention to address NCD burden globally. One of the major tools that work is taxation. And that is not only limited to SSBs. We have what is called the pro-head taxes: alcohol, salt, tobacco, and SSBs. So, in furtherance of this, the federal government in 2021, through the Fiscal Act 2021, introduced a 10 naira per liter excise duty tax on SSBs in Nigeria. First question is how they arrive at 10 naira per liter. That's another debate for another day. That was 2021. What we have seen since that tax was introduced were attempts to get it removed. There are two things you gain from introducing SSB tax. First thing you aim at is reduction in the consumption of SSBs, and then the reduction in the public health burden related to SSBs. Now, to get to that tipping point, you must be able to impose a tax that it's not absorbed by the industry, but that will lead to substantial, noticeable increase in the retail prices of the products, so that it will influence demand, so that the curve of demand will then come down. The significant point is, as at the time 10 naira per liter was introduced in Nigeria, a bottle of the favorite one you all know, which I will not mention, was selling for 80 naira or 100 naira. As at today, that is selling for 300, 400 naira. Because it was a fixed tax, the federal government tax is still 10 naira. By the way, I need to say that the 10 naira again is on a liter, which means by the time you look at 50 cl, the common one that we all see, it means that the tax on them is still 5 naira to 400 naira. Now, you've seen a lot of argument that says Nigeria economy is down, so they have to remove the taxes. They did not call us when they increased their prices to 300 naira, but they want to remove the 500 naira. Well, again, what do we need to gain is that we have done an economic study, and please, if you can pick today's Daily Trust. We put up an advert in today's Daily Trust. You see some of these arguments I cannot go into, particularly the one relating to our current state of economy. And what we've discovered from our economic study is that to get to that tipping point, the price per liter on a liter of SSB in Nigeria should be around 130 naira. So we're still a far cry for the recommended global best practices to be able to get the benefit. So two things I am saying is that we need to keep this tax for the health benefit, and then it can also lead to revenue that we can use for public aid, particularly when they are earmarked. Thank you.
Thank you very much for giving us those perspectives, especially when it comes to taxation and how that can also affect non-communicable diseases. One of our colleagues is online, discussant is online, we are not forgetting her. Just before I throw the session open to the audience for a few questions or comments and interactions, it gives me pleasure to call on Mrs. Eva Edwards. Is she already there? Of NAFDAC, to also talk about another aspect, which is regulating industrial trans fat. How has NAFDAC promoted healthier foods in terms of industrial trans fat. Mrs. Eva, are you there?
Yes, I am. Can you hear me?
Yes, we can hear you very clearly. Please go on.
Okay. All right, thank you very much. And good morning, moderator, and good morning to my co-panelists. It's a pleasure to join you. It's the panel discussion. So to answer our question, as we're all already aware, industrially produced trans fatty acids have been linked to increased risks of heart attacks and death from cardiovascular diseases, and they are not known to have any health benefits. So in line with the global call, I listened to the speaker, the panelist from WHO. In line with that call by the WHO for national governments of the member states to enact mandatory measures for elimination of industrially produced trans fatty acids from national food supplies, and essentially this is to protect public health. NAFDAC has revised the fats and oils regulations and set limits for trans fats. Now, the revised and now gazetted regulations now called the Fats, Oils and Foods Containing Fats and Oils Regulations 2022 has clearly stated in one of the sections, that is section 7, that fats, oils and foods containing fats and oils intended for human consumption, of which the content of trans fat exceeds 2 grams per 100 grams of fat or oil is prohibited in Nigeria. And I should add here that the process of revision of these regulations were very transparent. It was participatory and inclusive, and took on board comments from our stakeholders. So these regulations were launched in August last year by the Director General NAFDAC, Federal Ministry of Health and Social Welfare, and our partners, alongside another related regulation, which is the prepackaged food labeling regulations, because they are very closely related in terms of trans fats. Now, this other regulation makes provisions for the labeling of the amount of trans fats as a mandatory requirement. So that's an addition to that regulation. I might add that many of the big industry players have already reformulated their products in compliance with the regulatory limits that have been set, and others are on the way. This does not apply to micro and small scale establishments, which are at a different stage of development, and so they require more time, and for them it will be a phased approach. So the other thing we have done, along with ministries, relevant ministries, departments, and agencies, is that we have put in place, we have developed a strategy and roadmap for implementation of the fats, oils, and foods containing fats and oils regulations towards the replacement of these industrially produced trans fats, for replacement with healthier fats and oils. In that roadmap, we have put in what we will call high potential and actionable solutions, which span several approaches that will promote production as well as the availability of healthier alternatives of fats and oils. The strategy was validated, quite interesting, just 2 days ago, on Tuesday, 20th of August, and that signaled the ownership and collaboration for the implementation. And this will include, these actions will include raising public awareness, will include education, capacity building, knowledge sharing, technology transfer, and compliance monitoring, amongst others. We find that collaboration from all relevant stakeholders, and this cuts across going from food service establishments, so your hotels, the restaurants, the fats and oils subsector, the food manufacturing sector, the bakery subsector, and also government and academia. And this will significantly increase our chances of successfully reducing and replacing trans fatty acids with healthier alternatives. And now I close by saying that the benefits of setting these limits for trans fatty acids to not more than 2 grams per 100 grams of fat and oil are obvious, because as I said in the opening, as I started,
Oh, thank you very much, the representative from NAFDAC, for such lucid discussion on trans fats. So I think it's, you agree with me that this is a rich package. And the discussion definitely will be rich, comments and discussions. I'm thinking that the best way to take it is that we should be able to first number the people who may want to make comments, and then we can direct those comments to any of the panelists. However, I will just take my position as the moderator to make one comment, especially on sugar-sweetened beverages. When he was starting, he talked about sugar-sweetened beverages as a risk factor for diabetes, which is true, and that is where everybody's mind gets to. But really, sugar-sweetened beverages is also a risk factor for hypertension and many cardiovascular diseases. Of course, the commonest killer of diabetic patients really is cardiovascular. So that's another way. Sometimes when I work very closely with Professor Anuma, and we have been able to develop what we call diabetic cardiology. Then we keep struggling. Is it diabetes cardiology or cardiology diabetes? But I just want us to point that fact that sugar-sweetened beverages is also a major challenge in our country. By the time you see the average school bag of a child going to school in Nigeria at this time, it tells you that we are just sitting on a keg of industrial gunpowder. So I needed to point that fact out because people say that when a child is crying and is pointing in one direction, if you look for the father there, you don't see, look for the mother. On that note, I want to ask individuals who may want to make comments. Again, I would start with Professor Anuma. Please bear with me, even if I'm being, partial. So let's. Eight. Okay, I think 8 is a good number to start with. Okay, so number 1.
Good morning, everyone. Thank you, Professor Odili, the moderator of this discussion, and thank you for also to the discussants. I'm sure you had, I came in a bit late, but the little I heard was quite interesting. Yes, I want to add a little to this issue of sugar-sweetened beverages. The truth is, anything that tastes sweet in your mouth when you put it contains what we call refined sugars. And refined sugars are sugars in their most easily absorbable form. They don't need any processing. They don't need any digestion. They run straight into the blood to step up the blood sugar. And what is the challenge? The challenge is that we have a normal and so when we take these refined sugars that run straight to the blood, they keep stepping up the blood sugar, and then this organ called the pancreas, where the cells that produce insulin is. This is the famous chemical that helps us to utilize everything we eat as a source of energy and nutrition. These cells are stressed all the time to produce insulin to crash this blood sugar. And when we do that so frequently for quite a while, these cells get to a stage where they get exhausted. And when they get exhausted, there is no coming back. That's the problem. And so what we are saying is reduce the amount of refined sugars, reduce the rate at which you stress these cells so that these cells can see you till old age. Now, I'm always telling people, anything you can do, I've been in the field of diabetes for a long time, anything you can do to prevent having diabetes, it is worth everything. It is worth it. Then, the issue of taxation. The truth is, from WHO document, it is 20% taxation that can make any impact on health. Anything less than is not going to make any impact on health. So that's where we are going. So you see, when the industries are struggling with even 10%, we have a big challenge. And there is a need for education, because what I see in Nigeria is that people are very, when it comes to, and then cultural beliefs that are very counterproductive to NCD prevention. Professor Odile and Dr. Oji, you agree with me. We have cultural beliefs that are very counterproductive. And when we take too much sugar, the truth is that it is metabolized eventually and stored as fat. That is the truth. Because God is a perfect scientist. For every height, there's an ideal weight. Once you allow your height to go beyond what that weight is meant to carry, that is the beginning of problem. That's the beginning of diabetes. That's the beginning of hypertension and the consequences thereof. So please, we need all hands on deck to help us talk to the government to take this sugar sweetened beverage tax very seriously. I met people doing Zobo, and I said, why do you have to put sugar? Zobo on its own has, because it's one of the most popular drinks, it has a taste. But you know what they tell me? That if they don't put sugar, no Nigerian will buy. That's the problem. But we need to know that we are killing ourselves slowly. We need to know that and help ourselves. But we need the government to be able to understand what we are saying and help us with these industries that are fighting us so hard. People need to be alive to enjoy money now. Thank you very much.
Thank you very much. Number 2. This way, please. This way.
Good morning. I am Professor Chukwemeka Obaka, Commissioner for Health, Secondary and Tertiary Healthcare, Imo State. Panelists, Prof, I have 2 comments and 1 question. I'll be very fast. I have noticed all comments from the panelists regarding tobacco is preventing more people from taking tobacco. There's a part I think we are not paying attention to, which is tobacco cessation. We've done research in that area. How do we get people out of tobacco? It's a significant part of people of the entire prevalence of tobacco users. And I also believe that the more you take people out of tobacco, behaviorally, less people get to use tobacco. Let's not always think about taxation, policies, and co. Get more people out of tobacco use. So I wanted to paint that comment. Then secondly, it's tied to what the last professor said. Dietary modification in a hyperinflationary economy. Let's take out with some of these things. How can we achieve that? We keep saying the dietary modification, take a lot of whole grains, green and leafy vegetables, dairy milk. How much are those things? People still take more starchy foods that have high sodium content because they are cheaper. Let's also be asked, will these policy documents be alive to contextualize what is happening in Nigeria? Let's not just import anything that is being written abroad and just think it applies to us contextually. That is my comment. Will this policy document be still alive to be sure that those items will be contextually relevant to Nigeria? Then my last comment. NCDs can be controlled, or some control can be achieved by reducing high blood pressure, especially when it comes to hypertension, the main killer. But for those who already have high blood pressure, they need to take medicines. What are we saying about the supply chain of antihypertensives? How are we ensuring that the supply is effective and meets the high demand, but especially, which is where I'll end, and with anti-diabetics, the pricing is becoming too much. More people are not adhering to their medications and they are dying of complications. Why don't we also talk about that aspect? Thank you very much.
Thank you very much. Number 3.
Thank you very much. My name is Osai Hoi Eltel Chimawogugu. I'm a person living with type 2 diabetes and a member of the NCD Nigeria. I want to thank the panelists and everyone. We are almost all the issues are well represented, and I love the fact that they delivered most of what is talked about. Though to me, it's more of paper. We want action. I have a question for the brilliant presentation done by the Ministry of Health. Dr. Marlo, right? Pardon me. That was a brilliant one you delivered, sir. But my observation is inclusion of those living with the condition. We are having all these panelists having this issue because we've not included those living with the condition to be part of the design, implementation, and also ensuring the accountability of what has been, the policy that have been made is being executed properly. I have a question for the research department. He did very brilliant. For the past 8 years, I don't take, they call them bolio. I don't want to mention name, but if you permit me, Maggie. When I started it, people said it's not possible. Even in my party, you don't cook with that. How did I come to that? I saw a research by an Indian man. And I told them it is possible because the high content of salt in what we cook, every day adding Maggi, if you have not added Maggi, whatever they call it, bouillon, they feel it's not sweet. It's not true. I'm a health activist, and I know that it's very possible. If the food you are going to serve us here now, we should start with us before you go out to preach the gospel. So I started with myself. My children, I have 5 beautiful daughters. I taught them, I don't want you to live with diabetes. I'm preventing. Right now in school, we are campaigning about healthy eating. But you know the challenge? I'm glad he mentioned it. Schools are not even supporting you because we do live this. We do is in policy, but we don't execute it. So I'm glad we are having this conversation today. I have been in the school trying to get parents to sign the document that we can snap their children, because I represent IDF, International Diabetics Federation. And parents, please sign so that we can snap your children, showing that we have started teaching in schools diabetes in school. Since August last year is 1 year. I haven't been able to get 60 signatories from parents in 2 different schools. What does that tell us? Stigma, denial, people living in denial, people not supporting this good idea of school, we need to take diabetes to school. So the federal government is doing this. Please, we need to bring the policy to action, not just paperwork. And I want to commend Professor Numa for the great work you've done and giving us support. Thank you all, and God bless us as we go home with whatever is decided here today. Thank you.
Thank you very much. Number 4. Yes, that way.
Thank you very much. My name is Dr. Babagana Kundi Machina, Executive Secretary, Yobe State Primary Health Care Board. Thank you many thanks to all the panelists. I think I just need to add 1 or 2 things about the taxation for sugar, sweetened beverages, and for tobacco products. I think if we take into consideration the rising inflation and all of those things, it will be almost antithetical to fix an amount as the tax. As even if we tax 100 naira tax per 50 cl bottle or per liter, this will be overtaken by events in the next 1 year or so, why don't we put that as a percentage of the retail price? So whatever that retail price comes to, even if it crashes or it surges up, that should be the tax. And I go with the person that asked the first question or the comment that we should stick with like 28%. That way, we may not need to be reviewing these laws frequently. So if we just do that, I think it will be helpful. It will take care of itself as we go forward. Thank you.
Thank you very much. Number 5. Sorry, I think number 5 is behind. Okay.
Thank you very much, Professor Odili, for the moderator, and I want to thank all the discussants for the beautiful presentations. My name is Simeon. He says, well, I have a few comments briefly. The first one is on tobacco, and I want to commend what the ministry is doing as regards as tobacco control. The prevalence seems, or it's actually low in the country, and I think this is one of the areas where we are very lucky compared to developed countries and even other developing countries like our neighboring country, Ghana. I'm emphasizing this because this is probably one of the reasons why ischemic heart disease, even though on the rise, is still not in epidemic proportion in Nigeria. I'm talking about heart attack. And this is a condition that we don't have the capacity as at now to cope with. So I really want to encourage the federal government to put in a lot of resources in ensuring that tobacco is controlled in the country. My second comment is on salt. And the area I'm interested in, Professor Oji, is taste threshold. A lot of work has been done in this area in the past and has even been linked to offspring, linked to cardiovascular morbidity such as left ventricular hypertrophy. In our center, we found that diabetics who has hypertension has significantly higher salt taste threshold than those without. And it was very interesting for us because at a concentration of salt working with biochemistry, that an individual will say, I'm not feeling anything. Another individual will say, oh, this salt is just too much. So I think we should probably include salt taste threshold in our area of interest in the research. I'm not sure whether the diabetics are also thinking of sugar taste threshold. Yeah, I think these are the two comments I have. Thank you very much.
Thank you, Professor Sezu, the president of Nigerian Hypertension Society. Thank you very much. So this way, and then the last is that way. Thank you.
Thank you very much, the moderator and the panelists. I'm Dr. John Ovuraye. I'm a director in the Federal Ministry of Health. And I held the Gender, Adolescent, School Health, and the Elderly Care Division of the Federal Ministry of Health. I've decided to add my voice to what we are doing because we could see that it's the right way to go. When you talk about non-communicable diseases, let's view it in the area of burden. You will find out that in the past, it used to be more saddled with the older age group. But as of today, the non-communicable disease is also now spreading through the adolescent, the younger age group, meaning that the burden is now higher, and in cost of management, it's going to be huge. So the right thing we are doing is actually trying to make sure we fix it now so that we can address it even across all age groups, not only the older age group. Then, if we now take this and add it, look at it from the lens of persons with disabilities, you will find out that it becomes a double problem for those who actually have disability, because the fact that it's not communicable does not mean that it's restricted to only physically or able people. It means that persons with disability and other people can also have it. So when we are actually looking all through, let us now view it with the lens that it can affect different categories of people and different age groups, so that we're able to factor all of them in as we go about. Then the subnational, I'm glad that they're here, and they will do their best, especially the commissioners that are represented here, because they have a huge task in their hand to make sure at least this actually goes down to the state, because the implementation is at the level of the state so that we can get to the community. Thank you very much.
Thank you very much. Then the last one.
Good morning, everyone. I am Dr. Ige Busayo, the focal person for NCD in Ekiti State. I want to appreciate all the presenters, and I have two questions. I discovered that you talked about sugar sweetened beverages, but I want to ask about the effect of those beverages that are sugar-free. Because I've seen people taking coffee, taking Nescafe or Lipton tea, having palpitation. And if you test their blood pressure at that particular period, it will be a bit elevated. So what is the relationship between these sugar-free beverages and cardiovascular diseases? Then the second one, salt. Being a natural product and Maggi be an artificial one. And people believe, most especially at local level, that they still need both salt and Maggi. I don't know, maybe there is anything that can be done to the production of Maggi in order to reduce the sodium content of that Maggi, so that those people that believe that they still need the two will be helped by reducing the sugar level, the salt level of that Maggi. Thank you.
Thank you very much. I think the last is the person on cap there, because we have to quickly take quick comments from the panelists before we round off by 12 noon.
Good morning, everyone. I want to thank the moderator and all the panelists for doing justice to this topic and for the brilliant delivery of all the areas that they have talked about. My comment is focused on communication, and that will be to Resolve to Life, who spoke on salt intake. How do we communicate to people, the communities who are lay people that cannot measure the quantity of salt in their food, because the information given is 5 grams of salt per day, or equivalent of 1 level teaspoon. These people, sorry sir, these people cannot measure this. So how do we communicate effectively to these people to ensure that?
Thank you very much. I think the question is clear. Because of want of time, I will quickly ask the panelists, just 30 seconds. Any question or comment, majorly questions that concerns you, please quickly make a comment, because we must round off this session by 12 noon. So from that end, and then we move down. If you don't have any concern, then jump and pass.
Just two things. Quickly, the minimum recommended retail price of SSB is 20%. What we have today is not even up to 2%. If you calculate a liter, I mean, when we talk about a liter, so selling for 2,000, 3,400. Now, on the issue of sugar, and it inflation. So, said earlier, we actually didn't know how we got a fixed rate. That's a story for another day. But percentage more better adjusted. Number two is the issue of sugar-free. When you see products that are claiming to be sugar-free, they are not entirely sugar-free. There are other things that actually hide under them. There are about 8 different names for sugar that manufacturers hide under. So they spoke about front of pack labeling. We really need to get to the point to know what actually is in a product that Nigerians consume. And then you spoke about other products that are also not containing sugar, but you mentioned caffeine. Of course, you mentioned the issue. So that's it.
All right. Thank you, Prof. Thank you. Cessation is what I know the Ministry of Health in partnership with WHO they're working on. Then behavioral change. Yes, I know I can relate your concern as my concern, but from the same states. I know that in our states, people put tobacco in their marriage list. Yes, which we need to work on there in our states. Then talking about taxation, I think taxation still remains the best and the most effective way to control tobacco. Because after May 29th of last year, I don't know how many of us are still having our tank, car tank, to be filled. Before, fill the tank. But today, just give me the one of 20,000, off I go. So taxation will be nice. So about prevalence, the prevalence may be low now in Nigeria, but look at the absolute number. You know that Nigeria is still high, and we should not wait until when it spikes. We must control tobacco now. Thank you.
Thank you. Yes.
Okay, thank you very much, Professor Seso. I remember the question on taste. The issue is that human beings can always adjust. One key thing is create awareness, educate people. We have patients that you tell, reduce your salt level, and some of them say, I don't even put salt. I don't use salt again. They can adjust. It can be difficult, but they can adjust. Then that takes me to the second question around bullion. One thing we can do is to reformulate. It's not easy, but it's possible. And that is where the world should go to. Salt substitute is the way to go. Replace some of the sodium with potassium. Potassium reduces blood pressure. Just on the contrary, what we know, sodium increases blood pressure. Then third thing is create awareness. There should be media campaign. People should know that excessive salt is not good. There is no need using your salt in the food and then adding bouillon. Bouillon contains a lot of salt. 26% of the salt we consume in Nigeria from our study comes from bouillon. So we have to educate and educate and educate. Thank you.
Thank you very much.
Thank you very much. So just to add to what Prof just said, I'm just going to say this. Taste is acquired, right? What you are used to can change over time. Most people, what they are not used to from the beginning, that is where it becomes a problem. So we can also start this conversation with our mothers. We have kids, so what you give to them from infancy helps a lot down to adulthood. Also, before I come to the question, about bullion too, I know there is a WHO global benchmark for sodium level across different food groups. And bullion, I know, is also part of the food groups that has a global benchmark. And based from what Prof has said, we also know that the content of sodium in our bullion cubes currently is higher, far higher than what we have in the global benchmark as recommended by WHO. So another approach that we can also look at is also how do we get this reformulation to meet this global recommendation by the WHO. A question was also asked about communicating with people about this is an ongoing conversation. These are things that we're going to do even when we leave this place.
Okay,
and
thank you very
much.
much.
Sorry, sir.
Yeah, Dr. Malau.
I'm just going to say that we have also been supporting the Ministry of Health, and they have been developing strategies. So the Ministry of Health is going to take lead on that, on how to communicate this information to people, and I think we're just going to...
Thank you very much.
All right, thank you so much. So all the risk factors we've had, all the risk factors need to be tackled head-on. All stakeholders, all of us should be on board, contribute their quota so that we can address these risk factors collectively. Thank you. And somebody asked a question about essential medicine list, inclusion of people living with NCDs into the policy document, they have all been carried along. In the next session of the panel discussion, all these issues will be addressed. Thank you.
Thank you. WHO.
Yeah, thank you so much. Let me address a recurrent issue that has come. It's about taxation. Taxation of some of these products. Yes, thank you. Taxation is only effective if it impacts on the prices. Because the idea of increasing taxes is to reduce affordability. And therefore, when a country is implementing a tax policy, you must consider what system of taxation are you applying. Number two, what rates of tax are you applying? Does those rates and system impact on the pricing and therefore make those products less affordable? This is the only way you can reduce the consumption of those products. Finally, is that taxation is a win-win intervention because government increases revenue from taxes, which can be actually be earmarked into NCD programs, and at the same time, there's reduction of consumption of health products, and therefore secures health. Finally, is that in cessation, WHO has actually provided a clinical guideline for cessation services, even at the primary healthcare level. It was launched last year, and therefore countries are free to adapt this to their context and can be used even for training of primary healthcare workers on how to provide cessation services. And also, WHO has included varenicline and bupropion into the essential medicine list, and therefore I would even request Nigeria to actually include these products that are used for cessation services into their essential medicine list. Thank you.
Thank you. The concern of the people living with NCD is valid. There's rising cost of drugs, so we want to recommend that treatment management of NCDs be incorporated into the NHI services and the scheme. So this will also help to subsidize the cost of this essential medicine. And also the concerns of the director of the unit of adolescent health and elderly is also valid. There's rising burden of NCD among the adolescents. We've said that 80% of these adolescents are inactive. So in schools, there's a need for multisectoral collaboration with schools, Ministry of Transport, to make sure that people have a place where they can move, recreation facilities in workplace, and in schools they have sports fields, or both public and private schools have sports fields where students can be physically active and exercise while in school. Thank you very much.
Thank you very much. Can we put our hands together for the panelists? You must agree with me that this is really a very rewarding session. And for want of time and the fact that we have to go on with other aspects of the program, it gives me great pleasure to declare this session closed at this time. However, the conversation continues. Over tea break, collecting contacts, the conversation should please continue. Thank you very much, and do have a very nice day.
weeping. And that's part of the NCDs that we have to look after. And, and my sister and my special doctor is here, Professor Anuma. I'm here. I hope I'm doing well. And Dr. Oji, or Professor Oji now, thank you so very much. The zeal at which he does, take things with this sodium, I think we should propagate it very well. And so we have the ever hardworking Permanent Secretary of the Federal Ministry of Health and Social Development, my sister, dearest, Daju Kachalom, MNI. She's here with us. And I can assure you that this woman, please, she deserves a very, very loud round of applause. She had been at a meeting all day, all morning. But she did say to us that she would leave that meeting and be here in good time. So, and I know that at some point she needs to exist also to continue with the meeting. So, please, I would ask that we all settle down now. We also have the acting permanent secretary, at least for now, who is also here with us, the Director for Public Health, Dr. Anyaike Chukuma. Thank you so much. May I please call for the national anthem? May I now please call for the national anthem? Some people have actually accosted me for starting the panel. We cannot start with the high-ranking government official here. Shall we please all rise for the national anthem? And we are going to sing through the 3 verses of the national anthem. Can we have that up? If you don't have it, you also, on the immediate first page of the program, you have the national anthem. I know that some of us are just getting used to it. After the count of 3, if the IT is not ready, 1, 2, 3. Nigeria, we hail thee. Please be seated. Representative of the Executive Director, National Primary Healthcare Development Agency, representative of the Executive Director. Can we have one house, please? Of the Executive Director, National Health Insurance Agency, representative of the Director General, NADAC, Honorable Commissioners of Health present, Directors, Executive Secretaries of State Primary Healthcare Development Board, Director of Public Health, Federal Ministry of Health and Social Welfare, Directors of Federal MDACR present, Director of Public Health, Directors of Public Health, State Ministry of Health, representative of law enforcement agencies, our dear brother, the WHO country representative, representatives of World Bank, chairperson, National Tobacco Control Committee, executive director, NCDs Alliance here present, country reps from Resolve to Save Lives, MSH, PSI, Development Gateway, Hemophilia Foundations and other development partners here present, country leads of non-governmental organizations, civil societies here present, representatives from the academia, pharmaceutical companies, professional bodies, people living with NCDs who are here, and of course my constituency, the media, other partners here present. On behalf of the Federal Ministry of Health and of course and Social Welfare, I'd like to formally welcome all of us to the launch of the NCDC documents and of course the theme for which we are all here present gathered, Revitalizing NCDs, Prevention and Control in Nigeria and Strengthening Multisectoral Collaboration. Without wasting any more time, I'd like to invite the representative of the Permanent Secretary, who is also the Director of Public Health, Federal Ministry of Health and Social Welfare, Dr. Chukuma, to please give us a welcome address. Let's welcome him warmly, please.
Good afternoon, distinguished ladies and gentlemen. For the want of time, I just permit me to align with already established protocol. And just to welcome everyone to this very important occasion. It's coming at a very right time when the country is tilting towards a double burden country. The non-communicable diseases are trying to overtake the communicable diseases. At least all of us in this room will be a testament to what has been happening, people falling down and just dying without any reason. And so at this very important occasion, we have called everyone for us to put our caps, and very importantly, to look at the roadmaps, the documents, the policy documents that we must align onto. Nigeria is known as one of the countries with the best policy documents. And our problem has been putting that into action, making sure we walk the talk on which all of us sat down as stakeholders to develop. So we cannot have it another time than this time, where we've all come together to look at this. And we have chosen a very good theme, Revitalizing NCDs, Prevention and Control in Nigeria, Strengthening Multisectoral Collaboration. It is very important for us to know that we will not be able to achieve anything if we do not work together. Multisectoral approach is the note we must keep. And also ensuring that we engage the community actors, those in the communities, those at lowest level, knowing fully well that we must work together to achieve what we are looking for. And part of the strategies put by the current administration is to ensure that we correct all those anomalies, especially the inverse care law, which inequity in care of people with either communicable or non-communicable disease. And so, I warmly welcome all of you on behalf of the Coordinating Minister of Health and Social Welfare, Professor Ali Pate, for this very important occasion. Thank you.
Thank you very much. The director, who apparently was wearing like 2 caps for the welcome address, will take some goodwill messages. And it's important that we start from the one who should endorse all that we're doing. And I think that WHO deserves to be called as the first goodwill message, so that we have the endorsement of it. Please welcome with me our brother, the country rep of WHO, who has been here all day. He has been here with us at the very, very beginning. Can we please warmly welcome him to the microphone? Dr. Walter.
The Honorable Coordinating Minister of Health and Social Welfare, here ably represented by the Permanent Secretary, Federal Minister of Health and Social Welfare, my sister Daju. The Permanent Sec, represented by the Director of Public Health, distinguished guests and colleagues, please allow me to align with existing protocol. It's truly a pleasure to be invited here to witness this event, which will see the launch of several NCDs documents. And I must begin by commending the Honorable Coordinating Minister of Health and Social Welfare, Professor Muhammad Ali Pate, CON, and his team, for the leadership and commitment toward the prevention and control of NCDs. In Nigeria, like in the rest of the world, NCDs are overtaking communicable diseases. And we are hearing every day stories of people just falling. NCDs are truly beyond. So thank you for prioritizing the prevention and control of NCDs within the Nigeria Health Sector Renewal Initiative, which aim to save lives, reduce both physical and financial pain, produce health for all Nigerians, and protect Nigerians against emergencies. At this juncture, I will welcome warmly to Nigeria my colleagues from Afro and from HQ. They are sitting there in the corner, and who have come to support us. And some of them were part of the panel discussion that we had before this session. As I said before, NCDs are now the biggest killer worldwide, with low and middle income countries suffering the most. Premature death, loss to economic life, and many other negative consequences have become common business for us. The diseases, the main diseases, the cardiovascular diseases, diabetes, cancer, chronic respiratory diseases, and mental health share common risk factors. And we are happy that Nigeria has completed the STEP survey, which will give the real profile of those diseases. And I'm happy to take this opportunity to announce that WHO will be expanding its support that we have started in FCT to an additional 4 states of your choice. And we will drive very aggressive and effective NCD prevention and control program in those states, just to show the example of what it could be in other states, especially as we are rolling out the swap in the country. To stem the rising trend of NCDs and its risk factor, WHO, in collaboration with key stakeholders, supported the Federal Ministry of Health and Social Welfare to put in place strategies and plan to prevent and control NCDs. And I'm happy to witness the launch of some of those documents today. We are truly hopeful that this document will really serve the basis to accelerate, to really control the NCDs. I was privileged to meet some of the health commissioners after the forum, and they mentioned to me how NCDs have become a really nightmare. And we will work with them. We will work with the Federal Ministry of Health to launch a nationwide campaign to reach those who need to know, so that everybody will know his numbers, but not only knowing his number, will also control the numbers, whether blood pressure, whether sugar level, blood sugar level, and others. So we'll be happy to partner with the government of Nigeria to move ahead with this agenda. We cannot ignore NCDs anymore. They are no longer the disease of the Western world, the way we used to think. They are with us, and we will continue to support you as we deal with that part, that group of diseases. So on this note, I would like to congratulate you, PAMSEC, on behalf of the government in advance for this document that we'll be launching today, as I commit my organization and the entire UN to support you as you roll out different interventions. Thank you again for your attention.
We thank you again, country representative of WHO, particularly for your commitment to ensure that we reduce and contain the number of fatalities associated with non-communicable diseases. I will just wait a bit, maybe quickly, to re-echo the fact that the reality of non-communicable diseases has become a double burden on the health outcomes in Nigeria. Before, you would be told that diabetes is not for everybody, but now we know that diabetes also occur with children. Thank you very much. A lot of concerns were raised by the panel, and I'm sure that we have a lot of take-homes with it. What I just want to establish is that it's a collective responsibility. It's not just about you or your family or friends who are unfortunately might have fallen victims, but the fact that all of us must be out there, including the media, to ensure the prevention and the onset of NCDs. Now, I'd like to move on for another goodwill message, this time from the Executive Director, Resolved to Save Lives, Nanlop Ogbureke, who would speak on behalf of all other partners. Can we please welcome my sister, Nanlop, from Resolved. That's not loud enough. Their commitment is what has brought all of us together here today. Thank you.
Thank you, Auntie Moji. Good afternoon, everybody. I'm standing on existing protocol. I'm not very good with protocols, but I'm getting the hang of it as we continue. Your Excellency, the Coordinating Minister of the Federal Ministry of Health and Social Welfare, ably represented by the Permanent Secretary for the Ministry of Health, the Director of Public Health representing the Permanent Secretary. Welcome. I call him my DD. So it's good to have all my partners and collaborating partners. It's really an exciting time to be here. As Resolve to Save Lives, we've been looking forward to this event, putting as much effort as we can, working collaboratively with the Ministry of Health and Social Welfare, and collaborating with other partners who have supported us to this stage. I bring you greetings from our executive leadership, Dr. Tom Frieden, who is our President and CEO for Resolve to Save Lives, and also our Senior Vice President for Cardiovascular Health, who is Dr. Reno Gard. They had other engagements and couldn't be here. They also tried to join online, but that unfortunately didn't happen. I also want to recognize my team. They are somewhere in the crowd. They really backstopped for me, and I think they're deserving of acknowledgement. It's our honor, to join everyone here for this launching and dissemination these 6 critical policy documents. It's hoped that this will curb the rising burden of NCDs in our country and also contribute globally. As we all know, we've talked even at the panel, it's one of the leading causes of mortality and morbidity. 1/3 of the burden that we experience, health burden, is actually caused by NCDs. To put it in perspective, you would see that we have about every 70 seconds, at least one person dies from diseases related to non-communicable diseases. Over time, infectious diseases has been the main focus, and therefore you can tell that NCDs has been deprioritized. Not much investment has come, even in terms of funding. And that makes it very important for all of us to put our heads together, to collaborate and see how much we can do to push this forward. I would like to acknowledge and commend the government, especially the Federal Ministry of Health and Social Welfare, and recognizing especially the National Primary Healthcare Development Agency for providing exceptional leadership and coordination in developing these relevant policies and providing a conducive environment for partners and multi-sector actors and stakeholders to contribute to the prevention and control of NCDs in the country. A key example is the commitment and efforts in spearheading what we call the National Hypertension Control Initiative for Nigeria. And this we did with Resolve to Save Lives, and we're committed to continue pushing forward for this to be implemented to address hypertension as an epidemic in country. In the last 5 years, and in continuation of this, we've worked collaboratively with the government, and we've seen that we need to address, especially at sub-national level, working with the primary healthcare, at the primary healthcare level, to eliminate industrial trans fatty acids from diet, reduction of population consumption of salt, and seeing how we can expand the capacity at our primary healthcare center to adequately screen and treat hypertension. So about 19 million, almost 20 million Nigerian adults have hypertension. Some of them are aware, some are not, but we have a very low blood pressure control levels at 11%. But we've been working with Kano State and Ogun State. They will be representing, and you will be hearing from them, and also some of the community voices of what has happened at primary healthcare level, particularly enrolling and supporting the enrollment of patients on care through the state health insurance programs. Kano is leading on this, and we're hoping that the states that are represented in this room, the commissioners of health and the executive secretaries of the state primary healthcare development board agencies will take and follow suit. The impact of NCDs has been highlighted. The healthcare costs, decreased quality of life, poverty, and reduced mortality and productivity is something that is highlighted. Overall, we are committed as Resolve, and also with everybody here, particularly our government. I'm Nigerian, we're all Nigerians, and it rests on us to actually push this forward. We want to shift from policy to action. So we hope that these partnerships and collaboration will help us to implement high-impact NCD interventions in a way that we will be able to forge that formidable force or coalition to make the difference. So I thank you all for being here, and we look forward to the outcome of this policy launch in the near future. Thank you very much.
Thank you. Okay, we are still listening to our collaborators, and at this point I'd like to call on the chairperson, National Tobacco Control Committee. Okay, let's welcome her warmly, a former director in the Federal Ministry of Health. It's good to see you.
Thank you. Your Excellency, the Coordinating Minister of Health and Social Welfare, ably represented by our lovely Permanent Secretary, Mrs. Daju Kashalom. It is with great pleasure that I give you a good message on behalf of the National Tobacco Control Committee, which I chair NCD documents. NATOC, as you all know, is a multisectoral committee established by law and composed by representatives from ministries, several ministries, health and social welfare, education, NAFDAC, just to mention a few. Tobacco control is a major risk factor, as we have been told, for non-communicable diseases. And effective control of tobacco requires robust multi-sectoral collaboration and holistic approach, hence the establishment of NATOC as stipulated in the Section 2 of the National Tobacco Act. As a committee, NATOC sincerely appreciates the Coordinating Minister of Health and Social Welfare and the NCDs Division for coordinating the development of these documents. We strongly employ all stakeholders in the committee to implement relevant aspects of the document. In addition to these documents that we are talking about, policies and strategies, there's something that should begin with us, and we have already known it. Charity, they say, begins at home. We should, once in a while, test ourselves, go to the hospital, do a test to know where we are. That's how we have people dying suddenly of end result of cardiovascular disease, because they don't know how their blood pressure is, they don't know what their blood sugar is. So I want to employ all of us today that as we go home, go and test yourself, see where you are, do your kidney test, do your x-rays, know where you are, and report to the hospital with immediate effect. Once more, I want to thank all of you for coming, and I thank you all for your attention, and God bless all of you. Thank you.
Thank you very much. I think another thing we need to add to it is the fact that Nigerians must realize that they must look after their health so that it doesn't become so serious and irreversible before they go for their medical checkup. I think what the chairperson is saying is that we must deliberately ensure that we do go for medical checkup every year at least. We're moving on quickly. I'd also quickly to say that we have Emzor Pharmaceuticals here present, the executive director. We thank you for being part of this. At this moment, I'd like to invite a woman that has shown so much to ensuring that the Federal Ministry of Health is there for us. I'm proud because she's a woman. I'm also proud because she's Emini. But most importantly, she knows how to juggle her time. And I think that's why before we bring her to the microphone, representing the coordinating Minister of Health and Social Welfare, Professor Muhammad Ali Pate, she in herself deserves a very loud round of applause to make today a success that we are all here together. So I'd like to invite our very, very dynamic Permanent Secretary, Daju Kachalom, MNI, to please address us, declare this one open, and we'll move to the stand after her speech to present the documents. Thank you.
Thank you, Auntie Moji. Always a delight. Good afternoon, everybody. I would like to, first of all, commence with apologizing for starting officially at a later hour than we should have. It's because we had other engagements in the ministry that I could not leave. I had to be there. But I had assured the department I'd be here for 12 noon, but we have another 1 o'clock. So please pardon me. I am standing before all of you to represent the Coordinating Minister of Health, Professor Muhammad Ali Pate, who is away out of the country. And the Minister of State has another engagement. We were at the meetings together, and there's another one, and now we're going for 1 o'clock. So please pardon me if I read my speech, launch the documents, and I leave. And I'll be leaving alongside the Director of Public Health, who is standing in for me as well. So I will go right into my speech. Forgive me. WR, all the federal directors of the Federal Ministry of Health and all the agencies here present, and the former Director of Public Health, our inestimable development partners in whom we are all well pleased, our friends, stakeholders, oh, forgive me, the subnationals, our directors of public health, commissioners of health, if you're here, please, and to all of you. I don't want to reel out the guest list or the protocol, as it is called, but permit me to also recognize, before I go into the coordinating minister's speech, our members of press, without whom our messages would not go out to the world. You're all welcome and good afternoon. This address is by the Honorable Minister of Health and Social Welfare, Professor Muhammad Ali Pate, and I'm standing in for him. It is with great honor and deep sense of responsibility that I address you all today as we launch a series of pivotal national policy documents aimed at addressing non-communicable diseases in Nigeria. This event, titled Revitalizing NCDs, Prevention and Control in Nigeria, Strengthening Multisectoral Collaboration, reflects our collective resolve to confront one of the most significant public health challenges of our time. Under the visionary leadership of His Excellency, President Bola Ahmed Tinubu, GCFR, and in alignment with the renewed Hope Agenda, our administration is unwavering in its commitment to improving health outcomes of all Nigerians. This agenda, which prioritizes health and well-being, guides us as we work to achieve the health-related sustainable development goals, particularly SDG 3, which is good health and well-being. Non-communicable diseases, including cardiovascular diseases, cancers, diabetes, chronic respiratory diseases, sickle cell disease, and mental health disorders, among some, pose a severe threat to public health in Nigeria. These conditions account for 27% of all annual deaths in our country, equating to approximately 447,800 lives lost each year. Many of these deaths are premature, occurring between the ages of 30 and 70, highlighting the urgency of our intervention. Ladies and gentlemen, These challenges are exacerbated by demographic and epidemiological transitions, as well as the adoption of unhealthy lifestyles, such as tobacco use, alcohol consumption, poor diets, and physical inactivity. However, it is encouraging to note that the majority of non-communicable disease risk factors are preventable. And to address these pressing issues, our ministry, the Federal Ministry of Health and Social Welfare, has developed a comprehensive response encapsulated in several key policy documents which we launched today. These include the National Policy for the Prevention and Control of NCDs, the National NCD Task Shifting and Task Sharing Policy, the National Guideline for the Prevention and Management of Hypertension, the National Tobacco Control Strategic Plan of Action 2024 to 2028, Newsletter of People Living with NCDs, and the Federal Republic of Nigeria Official Gazette, Fat, Oils, and Food Containing Fat and Oils Regulations 2022. These are the documents that will be launched today. The launch of these publications is a crucial step in our nation's journey towards a healthier future. These documents are not just guidelines, they are instruments of change that will shape our healthcare practices and policies for years to come. Globally, countries that have implemented comprehensive NCD strategies have seen remarkable improvements in the public health outcomes. For example, Finland's successful North Karelia project in the 1970s, which focused on reducing cardiovascular disease through community-based interventions, led to a 70% reduction in coronary heart disease mortality over 25 years. Closer to home in South Africa, National Salt Reduction Program has significantly lowered the population's salt intake, contributing to a reduction in hypertension prevalence. In Nigeria, these publications are aligned with our broader goals under the NHSR2 and the Renewed Hope Agenda by providing clear evidence-based guidelines and fostering a culture of accountability and excellence. We are empowering our healthcare providers to deliver better care and our communities to take proactive steps towards healthier lifestyles. In addition, we are expanding cancer diagnosis and treatment infrastructure in 6 federal teaching hospitals, further bolstering our capacity to combat NCDs. We are also retraining 120,000 frontline health workers, which is also underway, equipping them with the latest skills and knowledge to meet evolving healthcare needs. My distinguished ladies and gentlemen, the federal government remains committed to expanding access to quality NCD services, enhancing health insurance coverage, and supporting local manufacturing of essential medicines. We will continue to prioritize the effective implementation of these policies, ensuring that our efforts translate into tangible improvements in the health and well-being of all Nigerians. As we advance in our fight against NCDs, I commend all individuals living with these conditions, as well as all those, committed to educating and supporting them. Your resilience and dedication are crucial to our collective success. Finally, I wish to extend my sincere gratitude to our key partners, including the World Health Organization, especially for extending to 4 other states alongside FCT and promising to partner with the ministry to create national awareness on NCDs. We thank you, WHO. The National Primary Healthcare Development Agency, thank you. The NHIA and other government agencies, our non-governmental organizations, and private sector stakeholders. Your unwavering support has been instrumental in our progress, and together we will continue to build a healthier and more prosperous Nigeria. And to let you know, that as a ministry that formulates policies, we're equally formulating a policy on health promotion. And we shall be celebrating the Health Promotion Day very shortly. So on this note, I want to thank you all for your kind attention. Thank you for listening. May God bless the Federal Republic of Nigeria as I declare this open on behalf of the Coordinating Minister of Health and Social Welfare, Professor Mohammed Ali Pati. Thank you.
Thank you.
Auntie
Well,
Moji.
thank you.
Okay.
Yes, I'm here, ma'am. Thank you so very much. You can see here where I'm standing. This is where the documents are, and please, Permanent Secretary, to be assisted by everyone on the front row here, would now make this a public presentation.
WR. Kano seats. I'm so sorry. You're welcome. Yes. Can you imagine? WR, Honorable Commissioners, PAMSEC, Director of Public Health representing me, and I representing the Minister, and all our distinguished development partners, stakeholders. Today, we launch these policy documents for a healthier Nigeria, better health outcomes. It is our job as the Ministry of Health, whether federal or state, to ensure that the populace have better health outcomes, we reduce their financial and physical pain, and ensure that we provide a healthier environment for everybody, and promote the elimination of non-communicable diseases, which has unfortunately taken over our country, and a lot of people are dying. I believe that with the launch of this policy document, that we'll begin to see a renewed and better Nigeria with our citizens who are healthier, and make a better nation, for a healthy nation is a well nation. So on this note, to the glory of God, to the glory of mankind, and for the betterment of a greater Nigeria, we launch this document for the use of all of us. To God be the glory. So here we have the National Guideline for the Prevention and Management of Hypertension in Nigeria. One. We have the National Tobacco Control Strategy 2024 to 2028, Honorable Commissioner Kano. We have the National Tobacco Control Enforcement Plan by the Tobacco Control Unit of the Federal Ministry of Health, Imo State. We have the National Tobacco Control Strategic Plan of Action 2024 to 2028. Have this, and then National Policy for the Prevention and Control of Non-Communicable Diseases in Nigeria, which Federal Ministry of Health, yes, this is ours, so I'll be holding that. WR. Oh, and last but not the least, a newsletter of people living with non-communicable diseases in Nigeria, and it will be held by you. So today we launch this policy document for the use of the entire country, both national and subnational levels, and for everyone, private sector as well, all our stakeholders, to the glory of God and mankind. Thank you. Auntie Moji.
Thank you all. Thank you very much. Congratulations. Yes, we will have tea break now for 20 minutes, and hopefully we can renew our sugar level. But remember that if it's too salty, don't eat. Bless you. Okay? All right. Okay, okay. The immediate, just one minute, don't leave. The door next to me, on my immediate left, will accommodate the front and the second row, while every other person will go through the back door. Thank you very much. We're breaking for tea, 20 minutes, counting from now. Please take your valuables with you, your phones, your laptops, and of course for the women, your bags as well. Take all your valuables with you as we break for tea. 10 minutes. At 20 minutes, counting from now.
Non-communicable diseases, that is the meaning of NCDs. Diseases that are chronic in nature, that is, they are lifelong. It is important to know that the diseases are associated with high mortality and high morbidity. So high morbidity and high mortality is one of the issues of non-communicable diseases.
And in fact, the country is treating towards a double burden country. A double burden country in the sense that the non-communicable diseases are even overtaking the burden of communicable diseases.
Non-communicable diseases, NCDs, are on the rise in Nigeria, as elsewhere worldwide. Among these, a silent but familiar killer looms: hypertension. Affecting millions, it strikes without warning, leaving behind a trail of devastation. Once seen as a problem for specialists alone, the burden of hypertension in Nigeria has grown too large to ignore. But amidst this growing challenge, a new approach is lighting the path to a healthier Nigeria.
We shifted the task to the basic healthcare level.
And once it is not complicated, it will be managed.
A patient at the barest, at the remotest, the lowest level of health care facility can get the hypertension screen.
If there is any complication, the protocol has also been designed in such a way that they can refer to the next level, that's the secondary health facility.
Recognizing the need for change, Nigeria has embarked on a revolutionary journey. Efforts such as the National Hypertension Control Initiative are transforming the way hypertension is managed by broadening care for simple, uncomplicated hypertension from specialist centers to the very heart of our communities through the primary health care PHC centers. This decentralized approach, guided by the minister's mandate to improve population health and align with World Health Organization HEART's model, is breaking barriers and expanding access to care for millions of Nigerians.
As you know that hypertension is like a silent killer. Many people are not aware that they have hypertension, but they will be moving around with it until they develop complications like stroke or heart diseases. That's when they present to the hospital. Sometimes it may be too late to do something. So therefore, this NHI program helps the populace of Kano to be scared, to have their blood pressure screened so that they will not develop these complications.
Yawanci dai ina jin ciwon kai, jijiri so tayin. So ɗana ba lafiya sai na kai shi asibiti. Da na kai shi an gama mai sai na yi tunanin to ni ma in tsaya mana a duba ni, sai aka duba ni aka ce ai ina da hawan jini. Na ce to abin ya ban mamaki, sai aka ce ai yanayi ne. Kowa yana samun kanshi a haka. To alhamdulillah ala kulli halin akan da kan ina yawan ciwon kai, zazzabi, jiri. Da na dora akan magani aka buɗe man fayil, to alhamdulillah gaskiya bana jin wata matsala yanzu.
Well, the Hypertension Control Initiative program started sometimes around 2021 in Ogun State. We started initially with 12 facilities in few selected local government, but as of today, we are currently in 52 facilities across the 20 local government.
Mo dúpẹ́ fún àwọn ìjọba wa kó má dáwọ́ ọdún kan báyìí dúró lórí ọ̀pọ̀lọpọ̀ èèyàn náà tó yóò bá jẹ́ pé ohun tó gbé jáde ọ̀pọ̀lọpọ̀ èèyàn á ti kú. A dúpẹ́ lọ́wọ́ Ọlọ́run pé gbogbo ìtọ́jú tó ń fún wa òun ni ò jẹ́ kí nǹkan kan ṣe wá mọ́. À ń rí oorun sùn bóyá yẹ ká sùn gbogbo ẹ̀ ń lọ déédéé.
We educate the people that you have to come for screening even you don't feel any symptoms in your body.
So, and for those people that we have treated, when they get back to their community, they inform their friends that this is what is happening at a health facility. You don't need to go to Federal Medical Center. They have BP medication at affordable prices.
But the journey is not without its challenges. Ensuring consistent pricing for medication and retaining patients in care are ongoing battles.
We are able to achieve some significant number of progress, but despite that, we're still having challenge. And one of the major challenge is, the financial hardship, we are having in country. People are battling with food, and now take care of pills every day for the rest of your life, in addition to hospital visits. So one of the key challenges is the supply chain, of that essential drugs, especially the losartan, and amlodipine. For people even to get, when we started, we had the seed money, which, like the drugs were given to us, and we put it through our drug revolving fund. But still, we're having significant number of lost follow-up, up to maybe 30%.
Clients that are on treatment decide not to come back to care, not to come back for follow-up, not taking their drug again. And this is as a result of asymptomatic effect of hypertension. They believe they are fine, they are okay, and they decide to drop drugs. So what we have put in place is, for now, is community engagement. And then secondly, we are planning to scale up to, we are already scaling up to more facilities
We believe that scaling up will make, the management and treatment closer to the people, and we hope that this will be reversed by the scale up to the 236 health facility across the state.
Primary health care is not just the first line of defense, it is the cornerstone of a resilient health system. By treating hypertension at the PHC level, we bring care closer to those who need it most, especially underserved areas. The success of this initiative is a beacon of hope. But to truly combat the growing tide of hypertension and other NCDs, we all need to join this movement.
We are bringing NCDs to the front burner. If you look at the budget for this year, NCDs came up. The funding was higher. Now, because of decentralization, we have funding for making sure that the capacity of healthcare workers builds. Using the glucometer to make sure we
Um, can we please be seated? Thank you very much, Dr. Coker, and sorry about keeping you forever. Yeah, okay. Shall we please bring her on? Yes, please, Dr. Coker. Can we please have her on? You're muted.
Can you hear me? I am unmuted. Hello? Good afternoon, all. I need some feedback if I can be heard, please. Good afternoon. All protocols aligned with that's been established. I'd like to bring congratulatory messages from Ogun State. Ogun State was one of the pilot states for the Nigeria Initiative on Hypertension Control. And from our experience, we gained some knowledge, which then means that the policies which are being driven will further enhance our ability to scale up nationwide. For instance, the policy on task shifting would augment the skills of our primary health nurses and midwives because during the hypertension control initiative, the nurses and midwife at the primary health centers were actually, the capacities were built to be able to screen and diagnose hypertension in the population. Since November 2020, when the initiative was commenced, Ogun State has been able to screen over 390,000 citizens, which is about 9% of our population. And out of those, we found that 6% were hypertensive, and we were able to initiate 52% of them on treatment. And there were some lessons learned from the attrition rate because we found that a lot of people will turn up to have their blood pressure checked. Unfortunately, they were not turning up to their nearest primary health centers. So it meant that they were struggling with transportation and they couldn't afford to come back. And we were able to overcome that by tracking and also by counseling, which has actually increased the control rate from 2% at the initial phase to 39% as we speak today. As mentioned in the video, promotional video, we've gone from 12 primary health centers to 52. However, the government haven't recognized the value that the hypertension control initiative has brought, in that citizens now have access to quality screening. They have access to quality management as well, near to their homes, as well as quality drugs at an affordable cost, which is subsidized by the Hypertension Control Initiative, DRF. So the state has now decided to scale up to every basic healthcare provision PHC. What does this mean? This is a means of sustainability aside from the insurance, because we're leveraging on existing structures, and with the sector-wide approach of the Honorable Coordinating Minister, we in Nigeria should be able to roll this and scale it up in a very short time, with the support of our partners, which include WHO, Resolve to Save Life, and currently there is Project Hope. So my hope is, with this document, we have a standardized way of managing, screening and managing hypertension, and using the human resource for health that is readily available to us at the primary health level, and with the collaboration of CSOs, the community, the subnational, the local government, and the Federal Ministry of Health, who is leading this project, that no Nigerian will be left behind without access to quality screening for NCDs, and also management at their doorstep. On this note, I wish to congratulate us once again, and look forward to a Nigeria with better health indices with regards to NCDs. Thank you very much. Over.
Good afternoon, ladies and gentlemen. Um, my name is Michael Adigbe. I work for NCDs for Health. The project director for the Tobacco Policy Action Fund for Africa. I'm here representing the MSH country rep, Mr. Ezechukwu Chidozie. He's unavailably absent. He had to leave for another engagement. So not to take much of your time, my message is basically to applaud all of us here today, particularly Honorable Minister of Health and Social Welfare, the Director of Public Health, and of course the NCD Division and the Tobacco Control Unit of the Federal Ministry of Health. For us, MSH is a long way. Coming here, particularly working towards the efforts of the ministry towards the NCD interventions. Particularly, MSH is supporting the ministry to implement tobacco control in the areas of smoke-free policy and graphic health warning. We are pleased to be announced that it has been a success. We are happy for the collaboration with the Ministry of Health to be able to develop the National Tobacco Control Enforcement Plan with contributions from the partner civil society and of course all of us in this room. I want to assure you that MSH will continue its efforts to support the Ministry of Health. It includes all of us here, stakeholders, to make this work. MSH is committed to continuing the support to the Ministry of Health across the nation to implement this tobacco control enforcement plan. Currently, we are in just 6 states, and the plan is to scale up using lessons that we have learned from these pilots to extend the implementation nationwide. So we look forward to partnering with all of us here, the state commissioners of health, and of course the coordinators, NCD coordinators here in the room. Thank you very much, and congratulations to the Honorable Minister of Health and Social Welfare, and to all of us here in this room. God bless the Federal Republic of Nigeria. Thank you.
Thank you very, very much. Yes. Quickly, we are going back to panel discussion, and I'd like to call on the moderator for the next panel, Dr. Kemi Sola Agbaoye for Nigeria Health Watch. Please, let's welcome her warmly. You recall that the last panel was not particularly inclusive. There was no woman on that panel. And I think that women should also be engaged. So I'm happy that there's a woman now. Good luck.
Thank you so much, Auntie Moji. Good afternoon, everyone. Good afternoon, everybody. Oh, okay. For a moment there, I thought most people were probably a bit drowsy from tea break. A big congratulations to the Federal Ministry of Health and Social Welfare on the launch of these policies. We're really excited about the sort of change this would mean to the NCD landscape in Nigeria, and how it would generally improve health outcomes as well. So to take us further in the discussions, to introduce myself, I'm Kemi Sola Agbaoye. I am the Director of Programs at Nigeria Health Watch, who are supporting this event. And also a very big congratulations or an acknowledgement of Resolve to Save Lives and other partners. This is a big win for Nigeria, and we're really excited. So to take us further, I'd like to introduce the panelists. Dr. Kelias Nsiambuza, who works at the WHO country office here in Nigeria. Please put your hands together for him as he comes up. Secondly, Dr. Anyaike Chukwuma, the Director of Public Health of the Federal Ministry of Health and Social Welfare, and the convener of this. Dr. Jonathan Eke, Director of Planning, Research and Statistics at the National Health Insurance Authority as well. Please put your hands together for him. Professor Felicia Anuma, Director of the Center for Diabetes Studies at the University of Abuja, Nigeria. Please put your hands together for her. Professor Obiageli Unodu, Director of the Center of Excellence for Sickle Cell Disease Research and Training at the University of Abuja. And finally, Mrs. Megan Adediron, President and Executive Director of the Hemophilia Foundation of Nigeria. Mr. Tunde Ojo, National Coordinator of the Mental Health Program. Put your hands together for him. And Dr. Kingsley Akinroye, who is the Director of the NCD Alliance in Nigeria. Sorry, I thought I had one more panel. Okay, it's coming up. Please put your hands together for him as he makes his way to the stage. Okay, so this is officially the largest panel I ever moderated. And if you know where I work at Nigeria Health, I do quite a number of these. So this just underlies how important these discussions are and how rich the conversations are going to be. So to get us started, I wanted us to start from a global perspective, and I would go to Dr. Kelias. I wanted to hear what WHO's priorities are for NCD, and you can start from giving an overview of what the landscape is at regional levels down to the national level, and then what your NCD priorities are at this time.
Thank you, moderator. Good afternoon, and good afternoon, my fellow panelists. Let me start with the global picture of NCDs. Just picking up to the first session we had in the morning, that NCDs have now overtaken communicable diseases at the global level. Every year, NCDs are killing 41 million people, an equivalent of 74% of all deaths globally. And we know most of the deaths occur in low and middle countries, including West Africa, including Nigeria, where over 80% of these deaths occur. They also occur in young people aged 30 to 69, and they die prematurely. We call them prematurely because they die before 70 years of age. In the African region, the trend is increasing. If you take a baseline of 1990, where we are with the NCDs now, it has increased over 67%. And the main driving factors we know and discussed in the morning are the risk factors. We talked about tobacco use, we talked about unhealthy diets, and we also talked about physical inactivity and harmful use of alcohol. So these are the driving factors. In addition, we also have increasing population, the aging population, that is also prone to NCDs. Now, when we come to the priorities for WHO, in WHO, we don't have our own priorities. We support the government. So what is the priorities for the government and the priorities for WHO? We are supporting them. However, our main role as WHO is to provide guidance. And the guidance, they come through the WHO guidelines. They come through the resolutions that are passed at the World Health Assembly or at the region committee. And also they come through in the form of treaties that countries can adopt and agree and sign to the treaties. So in a nutshell, I would say WHO priorities are those for the countries. We are supporting the priorities of the country to implement and provide guidance in terms of indicators and targets to measure progress. Thank you, and over.
Thank you so much. So indeed, you support national priorities. So to tell us about what those national priorities are and what the investments, the NCD investments of the Federal Ministry of Health and Social Welfare are, I will turn to the Director of Public Health, sir. What are the current NCD investments that the Ministry of Health and Social Welfare currently prioritizes? Dr. Anienke.
Good afternoon, everyone.
Good afternoon.
Well, you know, the health structure in the country is a bit complex, and primarily the Federal Ministry of Health and Social Welfare now happens to be the body mandated to develop guidelines, protocols, and frameworks, but in close collaboration with all the stakeholders, because our health system is built on the principle of primary health care, and we believe in bottom-up approach. So, but in coming up with those policies, we make sure we bring up every person. I think what we have shown this morning is a testament to one of those responsibilities. And suffice it to say that we didn't just stay in the office to develop those documents, but we kind of brought every person together and came with that. One. The second one is, if you have the capacity to develop guidelines and protocols, you should also come up with the training guidelines. And the the federal government is also driving in that stage to make sure you build the capacity of the focal persons, the directors of public health in the states, who are actually the ones to spearhead the actual implementation of whatever policies and protocols that have been developed at the national level. And it's very important for us to know, if we have to walk the talk, that is, making sure we implement what has been put down in the guidelines, there must be room for deliberate coordination and making sure that the right thing is done. And if you look at the structure of the country, we have the local government, which is responsible for the primary healthcare centers, and then the secondary, being done by the general hospitals, and then the tertiary. So for us to do that, we must build the capacity of the frontline health workers in that line, and to make sure that we'll be able to get the actual implementation. If you listen to my opening remarks, I said that we are the best in developing guidelines, but when it comes to actual implementation, we've not been doing well, and the government has taken a bold step. You also understand that the present administration has promised to build the capacity of frontline health workers, at least starting with 400,000 frontline health workers. That capacity is being driven by the federal government. The third one is making sure that the structures are working. If the primary health care is our nucleus, the first port of call, we should be able to make sure that everything is working. And that is where we have the revitalization of the primary health care centers, which is actually being driven by the NCDs. And the fourth one is to make sure that we sustain that tempo. In the national, last year, we drove the needle further by coming up with a guideline for decentralization of, the care or the NCDs to the local government and then the primary healthcare centers, and also making sure that all NCDs, including mental health, which is, one of the principles of primary health care, is also driven down. The fourth one is the federal government has also driven the extent of ensuring that the diagnostics, especially for diabetes and others, the diagnostic tools and even the commodities are being sent to the primary healthcare centers, even after building their capacity, to make sure that we'll be able to at least detect, early enough for intervention. The fifth one is also the awareness creation, because we are also ensuring that people know that this is the burden, people know that this is what they're supposed to do. People should now prioritize, NCDs. Of course, we will not be able to do that without the support of the private sector implementing partners. You see, the federal government is also trying to reach out to the implementing partners and then having a mapping to say, yes, if you are in this state, this other person should go to this particular state. You heard the announcement by WHO that they've started with FCT, and they've chosen 4 states that will be, dictated by, in collaboration with the state and the federal. So each partner that is coming will be able to say that you will need to go to this place, because looking at the burden, you'll be able to understand that you're supposed to come to this place first. The 6th one, whatever that we have to do, data is the light. Data is very important. In few weeks to 1 month now, we'll be able to come up with the step survey, which is being driven by the federal government, because we need to use the data to inform our interventions. So the federal government of, Federal Ministry of Health and Social Welfare has a lot of contributions ensuring that, NCD is reduced to the barest minimum, and to make sure that we achieve, the aim of reducing NCDs, because we're running towards the 2030 target globally. Thank you.
Thank you so much, sir. Thank you for, yes, please put your hands together for him. Thank you for sharing, doing a very comprehensive run-through of what will be needed to implement these policies. And like you rightly said, Nigeria has a lot of guidelines and policies, but what we need to work on is how we implement the policies. Thank you so much for that. And now, speaking of what you said about needing multisectoral collaboration and strengthening implementation at the subnational level, I wanted to come to you, Dr. Maimuna Hamisu, who is Head of Community Health Services at MPHCDA. And I wanted to hear your thoughts on what the key top facilitators and pitfalls to NCD management at primary health care level are. One of the policies that's been launched today is the addendum to the tax shifting tax sharing policy that will potentially institutionalize the management of NCDs at PHC level, which is currently not the case. So what are the pitfalls or enablers that you envision for NCD management at PHC level? Dr. Maimuna. Dr. Maimuna, yes. Dr. Maimuna. I'm sorry, what? No, I was actually asking Dr. Maimuna Hamisu that question. Oh. Okay, apologies, I mixed that up. Okay, so I'll come to NHIA then, Dr. Jonathan Eke. I wanted to ask what the initiatives the NHIA are currently or hopes to implement that will improve access to NCD services for the population, given how NCDs are such a huge burden, and the policies will be implemented now. What are the key initiatives that the NHIA is rolling out or will be rolling out that will improve access to NCD services?
Thank you very much. I don't know, you say what we hope to, or what are we doing?
Both.
Because
we're launching policies today, so both.
Okay, because we're already doing a lot in terms of NCDs. We do what we call demand-side financing, and this is built. When we want to start, we do what we call develop a benefit package. In our benefit package, I know that the NCDs, hypertension, diabetes, coverage of sickle cell disease, even cancers have been taken care of. So we're already doing that. The problem we have, one, we looked about the problems of demographic and epidemiologic transitions and implications on healthcare costs. They are driving healthcare costs to the moon. And that's the challenge we're having now. If that's where I'll start by what we are doing now, we are doing a lot to see how we can cover these costs. Also, a lot of Nigerians are getting this, and we realize that we cannot expand coverage sitting down here in Abuja. So that's why we encourage a lot of the states. In fact, we decentralize the health insurance implementation, and we're working with the states. If we have 36 plus 1 state health insurance agencies, and I know that the benefit packages of all the state health insurance agencies contain NCDs. And when we were developing when we were trying to commence the implementation of the Basic Healthcare Provision Fund, we developed what we call the National Basic Minimum Package of Care. And we ensured that the NCDs, especially hypertension and diabetes, we are mainstreamed in that benefit package. So we are doing a lot, and I know that we have a new DG, and it is part of his vision is to see that we provide coverage for even those non-communicable diseases that push people into real catastrophic expenditures. We had done a project on that, and it gave us a clue to where we are going. And we know that we are sitting here saying, I don't think we've been able to really evaluate the depth of the problem of NCDs in the country. We don't even know. We're only talking about hypertension, we're only talking about diabetes. There are a lot of other, the cancer problem. Nobody can sit there to tell you what the cancer problem is. And a lot of it, and these are the areas we are trying to see. For now, we are working, we have a committee that's working to see how we can develop a program to provide coverage, maybe not using the health insurance approach, to finance coverage for patients with conditions that will push them into poverty. For example, cancers, what to do, open heart surgeries, and a lot of all those type of conditions to cover. So, but coming back to what we are talking today, which is the coverage of non-communicable diseases, we are already doing a lot, and I believe and I hope that we will continue to do more. Thank you very much. Yeah.
Thank you so much. Quick follow-up question. Yes, please put your hands together for him. Are there specific initiatives amongst those that you just mentioned that you think could potentially increase access to NCD services? Or any ones that maybe are not currently being implemented that you think could significantly boost that?
You know, when you see the work we do, in fact, the more when you try to, in fact, it is better rather than creating parallel programs within a health insurance system, especially when you are pursuing universal health coverage. Most systems tend to go through a single package, a single system. So the way the NHI is structured is not one that will go about doing vertical programs we call initiatives. No. What we do is once we develop the benefit package, what we are trying to even do now is to see how the states can even bring up one benefit package for all of them to use, so that it will become a common package for everybody. And that makes the cost a lot cheaper and makes implementation and portability, so that whoever has any condition, wherever you go, you can have access to care. So in terms of initiative to cover non-steroidal, if there is what we call initiative that we want to do, I mentioned, I said we have a committee that we are trying to see how we can go even beyond the common conditions that people go through every day when they want to access care. I talked about the issue of area of covering open heart surgeries, cancers, and the rest of them. So these are the things, if you want to call it initiatives, but for the NHIS system, we prefer to work with our benefit package. So whatever you have anything you want to come in, let us put it in the benefit package. Once it's there, any member can be covered and can access the service. Thank you very much.
Thank you very much. So a unified benefit package for all of the states that includes NCD care is one key thing I'm taking away from what you just said. Thank you, sir. Okay, next I'll come to Professor Felicia Anoma, who is the director of the Center for Diabetes Studies at University of Abuja. Because right now we are launching these policies that we hope will reduce the prevalence of NCDs in Nigeria. And I was wondering if there are some noteworthy trends in diabetes prevention, control, and treatment that you think should be top of mind as we look to implementation of the policies.
Thank you very much for the question. Diabetes prevention. I am always saying that in our setting in Nigeria, the cheapest option we have is prevention. But for that to happen, we need to empower the people. We need to educate the people about risk factors and how to prevent getting there. We need the government to deliberately, intentionally develop and implement prevention programs for diabetes, for, of course, other NCDs, because we have common risk factors. We need policies and we need legislative changes that will create the political will for us to be able to prevent. A few years ago, I did a diabetes prevention program in 20 secondary schools in the Federal Capital Territory, both private and government. And we checked some of their parameters. We worked with 3,000 secondary school children. And what we got is quite scary. 32.9% of these children were either overweight or obese. Can you imagine that? 32.9% of 3,000 children. And the issue is this. The present generation of children with overweight and obesity, they are the very next generation of people with diabetes and hypertension. So we have a time bomb. It is left for us to act. But to act, we need a deliberate and intentional effort by government to create diabetes prevention programs, NCD prevention programs, with policies and legislative changes. There's a lot of ignorance out there, and therefore we really need a lot of education, education and education and education before we can feel the impact of prevention and reduce this burden. Because if you look at the cost of late diagnosis, the cost of poor control, the cost of managing the complications of these diseases, they far more outweigh what we will spend on prevention programs. And that is why I say is the cheapest option that we have. Well, as far as the picture of diabetes is concerned in Nigeria today, there was a systematic review, a meta-analysis in 2018. We are happy we have done the STEP survey. We are eagerly waiting for the result. But what we have as at then is that the pooled prevalence is about 5.77%. And when you look at the regions, Northwest was least 3%, but South-South was 9.8%, almost 10%. But I can say that this is still underreporting because of the challenges we have with research. I'm sure the national survey is going to shock us with the kind of prevalence that we have. As regards treatment, well, the last 1 year has been the most difficult year for our patients because the issue of accessibility and affordability of medications, and you know, about 60–70% of our patients who have diabetes are also hypertensive. A drug that my patient was buying 1 month dose, 5,000 before, is now 30,000 per month, naira. And many of our patients are on 2 drugs or 3 drugs to control blood pressure. 2 drugs or 3 drugs to control diabetes. Where is this human being going to get that money from? So I'm happy with what the representative of the National Health Insurance Authority has said. But my worry is, what is the depth of this coverage? Okay, even if we have improvement in the general coverage, what's the depth of this coverage? That is a very big question. I'll be very happy to have an answer to it later when we are having a discussion. Thank you very much.
Thank you so much, Prof. Anoma. I saw you eyeing Dr. Jonathan, turning him and facing him as you were making those comments. Those are very valid comments to make. The cost of treatment keeps going up. I like what you said about emphasizing prevention, targeting the younger generations, and raising awareness. Thank you so much for sharing those, Prof. Anoma. So next I'll come to, we've talked about diabetes now. Prof. Anoma has shared her thoughts on what she's seen in her practice and research. So I wanted to come down to Prof. Nodu to speak to us about sickle cell disease research. I was wondering if there are some major advances in managing sickle cell anemia that should be of top consideration for implementation of these policies, especially at the lower levels of care.
Yes, thank you very much for that question. I think I need to make some clarifications. Because when you have a disease that is genetic, an inherited disease, so comes from birth, and then you put it along with diseases that come, in adulthood as a result of modifiable risk factors, we fail to get the proper picture. So sickle cell disease is inherited when you have 2 people that have the carrier, so they are the ones that's the risk factor for sickle cell disease. If you have an AS and AC, marrying an AC and AS, then you have a 1 in 4 chance at each pregnancy that a child can have sickle cell disease. And this probability is regardless of the outcome of previous pregnancies. And so the prevalence, of sickle cell disease, if you do the STEP survey and you added sickle cell there, you will not be able to get the correct prevalence. You have to do the screening at birth. And newborn screening is actually not being done, systematically, across the country. We have a few pilot programs, some state-run screening programs, an attempt at a national screening program, and now, research-based screening programs where we are getting the prevalence of sickle cell disease. And this would be different from different parts of the country, but the best we have done in getting the current estimate is from the National Demographic Survey of 2018, when we had point-of-care tests that they actually used in doing the National Demographic Health Survey, and they were able to find that states in the Southwest, Northwest, Northeast, and certain parts of the country, there's a map that if you see the deep purple or deep green areas, they are the areas with the highest prevalence of up to 3%. And the interesting thing about that survey is that whatever we've been doing for the past 70 years in Nigeria within our healthcare settings was not able to make a dent in the prevalence of sickle cell disease, because we were just in the hospitals treating the patients without much education, without much genetic counseling, without much focus on primary prevention, because this is a 100% preventable disease. You understand? So when you go to pediatric clinics, you find hundreds of babies or children with sickle cell disease. If you go to the adult, you don't see so many. So what has happened? They have died. And that survey actually told us, when we analyzed it further, that children with sickle cell disease were 4 times, mortality was 4 times than ordinary children. And what was even worrying was that when they looked at the families with sickle cell children, they found that the older siblings of those children were also at higher risk of early mortality. And who would have known? So when you talk about when he was catastrophic health expenditure, I was straining my ears to see him say something about sickle, but nobody actually includes it. And it is very worrying, that. So that is as far as the diagnosis, knowing the prevalence. So what have we done by way of research? So one of the things that has actually happened is that there are evidence-based interventions that have been known to reduce the morbidity and mortality in sickle cell disease. The first one is newborn screening. Newborn screening followed with interventions, prophylaxis for infection, giving oral penicillin, giving antimalarials, educating the parents so that they know how to look after the baby, following these children up, pneumococcal vaccines, following them up and finding the ones who have risk of stroke, because stroke is very common in people with sickle cell disease. In fact, the commonest cause of stroke in children in our environment is sickle cell. So you follow them up by transcranial Doppler ultrasound scans, and then the ones who have risk of stroke, you put them on blood transfusion. But because blood transfusion is a bit difficult to come by in our environment, studies that have been done in Kano, Aminu Kano Teaching Hospital, over the past 5 to 6 years has shown that you can get the same degree of prevention by using a disease-modifying treatment called hydroxyurea. And so there are these evidence-based interventions. One of it, like I just mentioned, is hydroxyurea, which helps the body to go back into making baby hemoglobin that is protective in patients with sickle cell disease. But when we look at the disease registry that we have a big cohort of patients from 25 clinical centers in the country. And when we looked at the phenotypes and then the way we tried to analyze the data on how they were applying evidence-based intervention, it was low right across. But the worrying part is that hydroxyurea, which is this very cheap, cost-effective, disease-modifying drug, is only being used by 13.9% of our patients, despite its usefulness. This is a drug that when your patients are on, they don't remember the last time that they had a pain episode. They don't remember the last time that they had a blood transfusion. They are doing well, they are growing, and is really minimizing the morbidity and mortality. Yet, this drug.
Thank you so much. Just one quick follow-up question. Of these initiatives you mentioned newborn screening, followed by interventions, hydroxyurea. How feasible is it for these interventions to be implemented at lower levels of care, at PHCs?
Okay. Yes, actually, it is very feasible. And one of the things that we are trying to do now, we have a research study that is exactly meant to task shift the urea utilization from secondary, tertiary. That means train the people at primary health care, train them to be conversant and then to use the protocols and to monitor and all of that. Because our patients, the mothers of babies with sickle cell disease tell us that they prefer to have their care at primary health care centers. We have a study where we are screening for sickle cell in 25 primary health care centers in the FCT. And when we tell the mothers to come to the teaching hospital, they tell us, no, you got us at the immunization clinic, you found these babies, we want our care right there in the immunization clinics. Thank you.
Thank
so
you
it
so
is
much.
possible. Thank you.
Thank you so much, Ma. Yes, please put your hands together for her. Dr. Eke, it looks like people are coming for you today. You have a lot to say about NHI. I'll come back to you just so you can very quickly respond to those questions about the scale of coverage of NHIS, including lives enrolled and medications as well, because we've heard about hydroxyurea just now. So, but before that, I wanted to come to Mrs. Megan Adediran, who is the Executive Director of the Hemophilia Foundation of Nigeria. So we've heard about sickle cell disease. What are the most practical and cost-effective ways to ensure quality and quantity, quality and timely emergency services for blood disorders in Nigeria? I know I'm tweaking things a bit, but it's in a bit to get us moving quicker.
Good afternoon, everyone, and sorry, I have a cold, so I have a very bad voice. But I'd like to toe on the line with what Dr. just said now about lumping inherited conditions with conditions that are associated with lifestyle. For hemophilia, you have to be born with it to have it. And unlike sickle cell that has to do with genotype, for hemophilia, it's about your chromosomes. It's about you picking the X chromosome either from your mother or from your father that has a low level of factor 8 or factor 9. And that tends to give you the inability to form a clot when you have a bleed. From the introduction, I was introduced as the founder of Hemophilia Foundation. Why? In 1996, I had a son. 10 days into life, he was circumcised and he didn't stop bleeding. He bled for 5 days. His PCV got to 5%, and he had to be transfused as a 15-day-old child. The bleeding stopped and we were asked to go home. When he was 4 months, he injured himself at the top of his lips and bled for another 7 days and had to be transfused again. Fast forward to when he was 1 year, 9 months, he was eventually diagnosed with hemophilia. And I was told in 1997, December 27 precisely, by my physician, when I asked what was to be done for him who has hemophilia, and I was told nothing. And I asked why, and he said because treatments are not available in the country, and they die before the age of 3. I was holding a child that was 1 year, 9 months. I was told by a physician that should give me hope that he will die before the age of 3. I got home and I got thinking, and I related it to the stories of my maternal family. My grandmother lost 9 sons to post-circumcision bleeding. My great-grandmother lost 4 sons to post-circumcision bleeding. We know in this part of the world that circumcision is both a cultural and a religious belief. And most of these boys even die before they are diagnosed. So it has to start, like she talked about, newborn screening. There is a patient we have in the foundation that his first bleeding was from post-obliquan cord. And that boy bled to death. His younger brother is still alive. So I just wanted to give this for people to understand that there are other NCDs that are not about your lifestyle. It's not about tuberculosis, it's not about your sugar, it's just about who you are and how you are born. And we need to care about these people because they are also citizens. Presently, on our record, we have about 859 identified patients. But this is less than 3% of our expected number. The global prevalence is 1 in every 10,000 births. If we say we are 200 million Nigerians, it means we have over 20,000 Nigerians with hemophilia. And I'm only talking hemophilia. There are another condition called von Willebrand's. We have a high maternal death rate associated with PPH. Women with von Willebrand's have 80% risk of bleeding after delivery. I had to have an hysterectomy in 2013 because I'm a carrier of hemophilia and I bleed after every delivery and I require blood transfusion. I want us to think beyond placenta rupture, to think beyond all of this when we see PPH, and to think bleeding disorders. They are not diseases of the textbook. They live with us. They are among us. Excessive nosebleeds. Think deeper. Women with menorrhagia. Let's think beyond fibroid. Now, coming back to your question.
I'm so sorry, you can't come back to my question. But you have so passionately expounded on the topic. And, you know, it makes a difference when someone is speaking from a place of lived experience, right? So she has said, I'm sure there are a lot of professors and, you know, my senior ogas in this room. So it's not a textbook disorder. There are people who are living with these experiences and they need to be included in care. Thank you so much. If there's time, I will come back to you. All right, so next I would like to come to you, Mr. Tunde Ojo. What's in 1 minute? 1 minute, if you can please share what the key policies and initiatives that you think could significantly improve mental health care in Nigeria are.
Well, thank you so much. 1 minute, I'll try. So, well, what are the key policy initiatives that can drive mental health in the country? I would say that presently, most of the care for mental health are within very few hospitals. They are hospital-based. And most of the people that need mental health care are in the community. And so I believe that we need to take this closer to people, and that's where the issue of the tax shifting and integration of mental health into primary health care is very important. I also want to say it cannot be overemphasized, the role of financial protection for the vulnerable group, people that are affected by mental health conditions. This is associated with poverty, push them into poverty, whereas at this country, at this time, it is out-of-pocket expenditure. More than 98% of people that access mental health care have to pay from their pocket. That is double jeopardy. And, well, the National Health Insurance Act is here as the final person that takes the bullet. The financial protection, the pooling, and there are provisions that we can begin to explore. The National Authority Act talked about the vulnerable group. This is one place. The Basic Health Care Provision Fund also make provision for that. What are to give life to these provisions? I believe the area of raising awareness about mental health and but looking at mental health from the very promotion and prevention perspective. I think for time, I'll just stop at that. Thank you.
Thank you so much. Thank you so much, Mr. Tunji. Thanks for sharing those. The need to have health insurance coverage keeps coming up quite a bit on this panel. So, Dr. Kingsley, I'm Director of the NCD Alliance. I'll tweak your question a bit. And what I would like you to speak to in 1 minute or less is what the NCD Alliance's key takeaways for advocacy would be from the implementation of the policies, from what you've heard from your colleague, the panel. What is the advocacy focus, essentially, for the NCD Alliance?
Thank you. Thank you so very much. My name is Abiola Awe. Dr. Kingsley is unavoidably as absent. So I'm speaking for him. Thank you so much.
Apologies. Yeah.
So having had the statistics the lady had given, the death statistics. There's a lot for the NCD Alliance to do. Remember that the NCD Alliance is a body comprising of all these, including hemophilia, cancer, diabetes, sickle cell, mental health. The young man just spoke. And firstly, I want to say that we should have a multisectoral engagement. See, I'm meeting her for the first time. I've been looking for her a long time. We can do more if we push together. We can do more if we push together. So the policies have been launched today. It has opened up a vista of possibilities for NCD Alliance. What we would want to see as Alliance and what we are doing, as you see in the launch of the People Living with NCDs newsletter, which is one of our babies, is to have more engagements, first with the stakeholders, and then to support government. It's very important. We should have more support for the government, especially the NCD division. They're doing a lot. Considering the subnational efforts, the work they're doing now, it's not been done before. The NCD division is now working with subnationals, and we need to reach the people. I would say the opportunities for us are endless, and we want to see more collaborations with other stakeholders and then with the government. Thank you very much.
Thank you so much. Thank you for keeping that concise. So I'm supposed to give a closing statement, but instead of doing that, I will hand the mic to Dr. Jonathan Ike to speak about financial risk protection for NCDs, given how that has been mentioned multiple times on this panel. And that will be the end of this panel discussion.
Thank you very much. Let me start by, let me answer Prof.
Sir, in 1 minute, sir.
Okay,
just 1 minute.
The coverage depth we have is quite enormous. It's just that a lot of us and a lot of the providers and the HMOs, whatever they try to do. But when we know, we have to correct that. And for you talking about sickle cell, I can assure you that even your US covered under the NHS is there. Understand? So that's not what I'm trying to do, because even while you're asking this, I'm asking the this, and that's what they're referring to me now. All right? So we're all committed to see that Nigerians have access to. It's our country, they are our brothers, our sisters. So our work is to see that we improve the health outcomes of the country. One way is to make sure that people don't go into poverty because they have a need to go to a hospital. So that's just what I want to say. Thank you very much.
Thank you so much, sir. So this just underscores the importance of awareness. A lot of awareness has to be done in the implementation of these policies, in educating people about their rights, and in expanding coverage of services. Please, apologies, we can't take any questions for this panel, but please put your hands together as I invite my panelists to take a photograph. If you could please step forward. Thank you so much for sharing your thoughts and sharing your expertise, and thanks everyone for listening.
Sir, please, can you meet members of the panel if you have a one-on-one with them, please? Because of our time, we need to work on the time. Thank you, and I'm sure that Megan will be one of the people that they want to speak to. However, we are quickly going to rearrange here to take in 3 more presentations, particularly the presentation from the National Primary Healthcare Development Agency. It's important that we do this. We have kept the Primary Healthcare Development Agency for the last because first, initially we couldn't bring them in, but now it's important for them to listen in to what every other presenter has to offer so that we know what the primary healthcare can do. It's the first port of call, actually, and the primary healthcare is so important to what we are doing here today. I have here Dr. Suleiman Lamurde, who is representing Dr. Maimuna Hamisu, Director of Community Health Services from the National Primary Healthcare Development Agency. Please can we welcome him very, very warmly to the microphone. Yes. Primary healthcare is where we need to go. And because we know that you are also revitalizing. So let's hear what you have for us for NCDs. Thank you.
Good afternoon, Auntie Moji, for that pulling of my legs and that of my organization. Thank you. The Honorable Minister, ably represented by the Permanent Secretary, Federal Ministry of Health and Social Welfare, our PAMSEC, ably represented by the Director of Public Health, our Honorable Commissioners of Health, our Executive Secretaries here present, and then leaders of development world. Good afternoon all. I like what Auntie Moji said. They left us for the last. So thank you for that. A lot have been said about NCDs. I don't want to repeat or re-echo what have been said. But I bring you goodwill message and greetings from our Executive Director, Dr. Muyi Aina, who is unavoidably present here due to exigencies of his office. The Director of Community Health, Dr. Maimuna Hamis, will also have been here, but she cannot make it due to other engagements outside Abuja. Now, we have said it all. For us to move forward and achieve universal health coverage, we need to deal with the silent killer, which is NCDs. A lot of comments have been said. How do we get it right? We have gotten the policy document. If we have the policy in place, we all agree that there's a huge task, which is implementation or operationalization of the policy. And to do that, you need the gatekeepers at the community level. I agree with everybody, and it's a fact, that only if we strengthen the PSC system, then and only then can we be able to achieve universal health coverage. And only then can we reduce the scourge and menace of NCDs that is becoming an increasing burden to our health system. Let me quickly pick up on some few points. Most of Nigerians access their care from the PHCs. Therefore, if the PHCs are not fully revitalized, we cannot be able to achieve this objective of improving the health care space. You are all aware we are doing a lot of effort in revitalizing these PHCs. And 90% of the NCD data we have are generated from the primary health care center. It may interest you to know that in the last 2 or 3 years, we have screened over 11 million Nigerians using the PSC system, among which about 1.9 million Nigerians have been found to have an elevated blood pressure. Out of this number, about 1.2 have been linked to care. The question is, why are we using hypertension? Hypertension is the entry point for all NCDs. If we are able to get hypertension management in place, then other NCDs like diabetes, kidney diseases, cancers can also come into limelight. And we are working closely with our gatekeepers, WDCs, civil society organizations, traditional and religious institutions. I want to believe in this whole. We have not less than 5 to 10 executive secretaries of primary care board. Are they here for recognition? ESCs of primary care board, are you here? Can you stand up, please? Let's see the numbers. How many of them are here? Please, can we clap for them? Can we clap for them? Yes. Over 10 of them are here. Now, what are we saying? You can take your seat, please. If we don't have the synergy we have with the primary health care board at the states, we cannot achieve anything. Let me emphasize on one thing, health education. Health education is the key, is the major key to achieving successes and bringing transformation in the health space. But how do you educate these people? You must engage them. Some of our community members are in hard-to-reach areas where you don't even have access roads. You don't have accessibility, no power, no internet. So we need to work closely with our gatekeepers to ensure that we have a strategy for health promotion and education to achieve universal health care coverage. Before I round up, I want to commend the organizers of this workshop. It's not easy. This requires a lot of energy and effort. I congratulate the Federal Ministry of Health for bringing this policy, which we've started. I know we've worked with WHO and resolved for the past 4 or 5 years. So I congratulate all of us in getting this policy. I also want to tell the House that the training of the 120,000 healthcare workers that we are currently leading, NCDs has a very prominent role. It's part of it. And all those that have participated in the training will attest to that. Finally, MPSCDA and all its development partners are open for stronger and more collaboration in ensuring that we have moved NCDs to the next level. So on behalf of Dr. Mui Aina, the Executive Director, and my own Director, Dr. Memuna Hamisu, I want to congratulate the organizers and thank you for giving us an opportunity to speak at this occasion. Thank you, good afternoon, and God bless the Federal Republic of Nigeria. Thank you.
Thank you very much. Another round of applause, please, for Dr. Lamurde. Okay, we'll quickly listen to short, very, very short goodwill messages from EMZO and Codex. Please, can you both just come, the representative? EMZO, Codex. Please, you have a minute each.
Good afternoon, everyone. If I would be permitted to stand on the existing protocols. My name is Uzome Zoke. I'm an ED at EMZO, and I bring you greetings of unlimited wellness. We are a wellness company. A goodwill message I had to look up is a combination of expressing approval, kindly approval, and support. So I'm staring at Dr. Anyike because you're representing all the representables here. So warm approval with accountability is what you'll have from us. And strong support. Local manufacturers have been re-strategizing and making massive investments so that we can manufacture the drugs that are required in the management of NCDs locally to deliver on medicine security. And if the Honorable Minister, Coordinating Minister of Health was here, I would thank him personally for being instrumental in driving the strategies, even with the Ministry of Finance, that will lead to what Madam was talking about, lower cost of drugs. There's also the community pharmacists president here, because they also have a role to play. But I just wanted to make an observation. We've heard so much about accountability, personal accountability, and how charity begins at home. So one of the messages from the pharmaceutical sector would be, if you continue to have chance encounters with plates of small chops, as we did today, and they are winning you, we're here for you, and we'll see you at the pharmacy. Thank you so much. Thank you, Madam.
Very important. All right. Codex, yes. You have 1 second, but before then, PSI, are you also around so that you can be ready? Thank you. 1 minute.
Okay, thank you. Thank you. Good afternoon, all. The Honorable Minister of Health, and standing on all existing protocols, I bring you greetings from my GMD, Mr. Samuel Ogunjimi. My name is Kim Jakim, and we are really excited with what's going on, and we really commend the Ministry of Health, the Department of Non-Communicable Diseases, or the Unit of Non-Communicable Diseases under the Director of Public Health for advancing the launch of these guidelines. It's very important to say that in everything we do, diagnosis is the first step to achieving a good healthcare delivery. And for us as Codex, a health tech company, we are actually driving that force towards local manufacture and access of diagnostic tools. We've made that giant step with the locally accessible manufactured blood glucose meters and strips here in Nigeria, the first of its kind in sub-Saharan Africa, and located in Lagos, Ilupeju. We believe that diabetes as a non-communicable disease is not what should be meant for diabetics alone. Every household should have a glucometer in their homes to continuously or constantly monitor their glucose levels at the least monthly. And when these products are accessible because they are locally manufactured, we know that driving non-communicable diseases or identifying them early becomes the first step. As Codex, we believe that when we continue to backward integrate what we currently import, like in the sickle cell disease space, where we have POCTs, as Professor Nodu has mentioned, for diagnosing even newborn babies or screening newborn babies. Local access is the watchword for us, and technology transfer is what we are into. We believe that in driving that, we will show constant support to the Ministry of Health and driving the non-communicable disease diagnosis. On behalf of my GMD, we appreciate what the Ministry of Health is doing, and we continue to pledge our consistent support. Thank you all.
Thank you very much. PSI? Oh, okay. All right, we'll move on, and we'll now watch the documentary. Can we have the documentary on now, please? It's only 10 minutes.
Non-communicable diseases, that is the meaning of NCDs. Diseases that are chronic in nature, that is, they are lifelong. It is important to know that the diseases are associated with high mortality and high morbidity. So high morbidity and high mortality is one
as the National Hypertension Control
non-communicable diseases, that is the meaning of NCDs. diseases that are chronic in nature, that is, they are lifelong. It is important to know that the diseases are associated with high mortality and high morbidity. So high morbidity and high mortality is one of the issue of non-communicable diseases.
And in fact, the country is treating towards a double burden country. A double burden country in the sense that the non-communicable diseases are even overtaking
we seem to be having a technical hitch.
Are chronic in nature, that is, they are lifelong. It is important to know that the diseases are associated with high mortality and high morbidity. So high morbidity and high mortality is one of the issue of non-communicable diseases.
And in fact, the country is treating towards a double burden country. A double burden country in the sense that the non-communicable diseases are even overtaking the burden of communicable diseases.
Non-communicable diseases, NCDs, are on the rise in Nigeria, as elsewhere worldwide. Among these, a silent but familiar killer looms: hypertension. Affecting millions, it strikes without warning, leaving behind a trail of devastation. Once seen as a problem for specialists alone, the burden of hypertension in Nigeria has grown too large to ignore. But amidst this growing challenge, a new approach is lighting the path to a healthier Nigeria.
We shifted the task to the basic healthcare level.
And once it is not complicated, it will be managed.
A patient at the barest, at the remotest, the lowest level of healthcare facility can get a hypertension screening.
If there is any complication, the protocol has also been designed in such a way that they can refer to the next level, that's the secondary health facility.
Recognizing the need for change, Nigeria has embarked on a revolutionary journey. Efforts such as the National Hypertension Control Initiative are transforming the way hypertension is managed by broadening care for simple, uncomplicated hypertension from specialist centers to the very heart of our communities through the primary health care PHC centers. This decentralized approach, guided by the minister's mandate to improve population health and align with World Health Organization HEART's model, is breaking barriers and expanding access to care for millions of Nigerians.
As you know that hypertension is like a silent killer. Many people are not aware that they have hypertension, but they will be moving around with it until they develop complications like stroke or heart disease. That's when they present to the hospital. Sometimes it may be too late to do something. So therefore, this NHAI program helps the populace of Kano to be scared to have their blood pressure screened so that they will not develop these complications.
Ban san ma ina da shi ba. Yawanci dai ina jin ciwon kai, in ji jiri so time. So ɗana ba lafiya sai na kai shi asibitin. Da na kai shi an gama mai sai na tunanin to ni ma in tsaya mana a duba ni, sai aka duba ni aka ce ai ina da hawan jini. Na ce to abin ya ban mamaki, sai aka ce ai yanayi ne. Kowa yana samun kanshi a haka. To alhamdulillah ala kulli halin akan da kan ina yawan ciwon kai, zazzabi, jiri. To da na dora akan magani aka buɗe man fayil. To alhamdulillah gaskiya bana jin wata matsala yanzu.
Well, the Hypertension Control Initiative program started sometimes around 2021 in Ogun State. We started initially with 12 facilities in few selected local government, but as of today, we are currently in 52 facilities across the 20 local government.
Mo dúpẹ́ fún àwọn ìjọba wa kó má dáwọ́ ọdún kan báyìí dúró lórí ọ̀pọ̀lọpọ̀ èèyàn náà tó yóò bá jẹ́ pé ohun tó gbé jáde ọ̀pọ̀lọpọ̀ èèyàn á ti kú. A dúpẹ́ lọ́wọ́ Ọlọ́run pé gbogbo ìtọ́jú tó ń fún wa òun ni ò jẹ́ kí nǹkan kan ṣe wá mọ́. À ń rí oorun sùn bóyá yẹ ká sùn gbogbo ẹ̀ ń lọ déédéé.
We educate the people that you have to come for screening even you don't feel any symptoms in your body.
So for those people that were afflicted, when they get back to their community, they inform their friends that this is what is happening at a health facility. You don't need to go to Federal Medical Center. They have BP medication at affordable prices.
But the journey is not without its challenges. Ensuring consistent pricing for medication and retaining patients in care are ongoing battles.
Able to achieve some significant number of progress, but despite that, we're still having challenge. And one of the major challenge is, the financial hardship, we are having in country. People are battling with food, and now you have to take care of pills every day for the rest of your life, in addition to hospital visits. So one of the key challenge is the supply chain, of that essential drugs, especially the losartan, and amlodipine. For people even to get, when we started, we had the seed money, which, like the drugs were given to us, and we put it through our drug revolving fund. But still, we're having significant number of lost follow-up, up to maybe 30%.
Clients that are on treatment decide not to come back to care, not to come back for follow-up, not taking their drug again. And this is as a result of asymptomatic effect of hypertension. They believe they are fine, they are okay, and they decide to drop drugs. So what we have put in place is, for now, is community engagement. And then secondly, we are planning to scale up to, we are already scaling up to more facilities.
We believe that scaling up will make, the management and treatment closer to the people, and we hope that this will be reversed by the scale up to the 236 health facility across the state.
Primary health care is not just the first line of defense, it is the cornerstone of a resilient health system. By treating hypertension at the PHC level, we bring care closer to those who need it most, especially underserved areas. The success of this initiative is a beacon of hope. But to truly combat the growing tide of hypertension and other NCDs, we all need to join this movement.
We are bringing NCDs to the front burner. If you look at the budget for this year, NCDs came up. The funding was higher. Now, because of decentralization, we have funding for making sure that the capacity of healthcare workers are built, especially for NCDs. 2, for the diabetes mellitus, using the glucometer to make sure we'll be able to. 3, the government has come up with a lot of policies in a multi-sectoral manner. In fact, we have the technical working group that will provide technical guidance to the government in a very, bringing every stakeholder to make sure private sector, the government, the manufacturers of medicines, the manufacturers of health commodities, every person on the table to make sure. Because it's no more a disease that is hidden. People are coming up. And then we're bringing in the health promotion aspect of it. Awareness creation, very important. Why are we having a lot of cancers? Why are young people coming up with high blood pressure? Why are young people born with diabetes?
We urge all stakeholders, governments, development partners, philanthropists, and the good people of Nigeria to champion this cause. Together, we can combat hypertension and other non-communicable diseases and pave the way for a healthier future for all.
Thank you very, very much. Right. We also would like to acknowledge our online participants. Thank you for staying online. At this moment, we would call for lunch. Lunch would be so directed. Oh, we can do, okay. Well, I have another direction here that we can actually have the 30 minutes presentation before we go for lunch. Is that unanimous decision, right? Okay, please let's welcome the presenter, the barrister himself. Please let's welcome him.
Negatively affects people's health more than anything else.
Okay. Good afternoon, everyone. So we're going to have a conversation on how we can communicate about NCDs for better impact. So on your paper it shows empowering change, communicating to combat NCDs. I wouldn't really want this to be like a technical presentation because we've heard all the technical details from Dr. Anyike and his egghead colleagues. So pretty much everybody in this room should be an expert on NCDs, their causes, what to do and what not to do. But for me, the important thing is to make sure that as we live here, we are empowered to make a difference. That's the whole idea. You have a bunch of publications that have been launched today. They will remain just publications if they are not implemented, if they are not actioned upon. So before we start, I have a short clip. I have 30 minutes, I know, so I'm going to use the time very efficiently because, as I said, we are all experts already here. So the tech guys, if you could just...
Negatively affects people's health more than anything else. Alcohol, cigarettes, the donut, hamburger. Sure, they're all pretty bad for you, but most people know that and at least try to limit their intake somewhat to these items, even a little bit. But it's the things we don't think about that can really cause damage. Things we use every day so regularly we don't even think about how its constant use could actually be killing us. The real culprit is the chair. We were given legs for a reason. Most third world cultures don't even have chairs, and they walk an average of 10 miles a day. We in the modern world, on the other hand, spend most of our entire waking days sitting down. People go right from bed to sitting on the toilet, after which they sit at the breakfast table, then they sit in a car as they drive to work and spend the entire day sitting at a desk, only getting up to sit in the toilet and in the cafeteria. Then they sit in the car to drive and sit at the local bar for happy hour. Then when they've had enough of that, they go drive home and spend the rest of the day sitting in a comfortable chair watching TV before they crawl to bed to recover from all the physical exertion that day. And when people go out, they sit at a restaurant or a movie theater. Sitting all day is far worse for you than you might think. A 2010 American Cancer Society study following over 123,000 people from 1993 to 2016 found these alarming results. People who were inactive and sat for over 6 hours a day were 94% more likely to die during the time period studied than those who were physically active and sat less than 3 hours a day. That's almost 100%. And get this, findings were independent of physical activity levels. The negative effects of sitting were just as strong in people who exercised regularly. 60%, that's over half of employees surveyed, were convinced they would be more productive if they had the option to work on their feet. Medical experts have started referring to long periods of physical inactivity and its negative consequences as sitting disease. Below this video are links to an endless list of medical studies showing physical inactivity and low fitness are serious threats to cardiovascular health. Even with a low body fat index, sitting has been linked to non-alcoholic fatty liver disease. Studies showing differences in brachial and femoral artery responses to prolonged sitting. Studies showing reducing sedentary time may protect DNA. Sedentary lifestyle has been linked to depression. How sitting less increases muscle mass. Multiple studies linking diabetes to inactivity and sitting. Cells in idle muscles don't respond well to insulin, so the pancreas produces more and more, leading to diabetes. And how 5 minutes of standing every half hour can improve glucose metabolism and really help postmenopausal women who are pre-diabetic. Blood pressure drops when standing compared to sitting. A Cornell University study found that sitting more than 1 hour induces biochemical changes in lipoprotein lipase activity, that's an enzyme involved in fat metabolism, and glucose metabolism, leading to deposits of fats in adipose tissue rather than being metabolized by muscle, and increases heart attack risk, coronary heart disease, and kidney disease. This happens in both fit people who do regular aerobic activity and also unfit overweight people. This means regular exercise does not cancel out these effects of sitting the rest of the day. Sitting a lot is asking for trouble, no matter who you are. Another study at the University of South Carolina found that men who reported more than 23 hours a week of sedentary activity had a 64% greater risk of dying from heart disease than those who reported less than 11 hours a week. And many of these men routinely exercised. Cholesterol, blood sugar, triglycerides, diabetes, heart disease, and a number of health problems all became apparent. Studies have linked sitting to a greater risk for colon, breast, and endometrial cancers. Sitting for long periods of time can cause blood clots to form, which can travel to the brain, causing a stroke. Speaking of blood clots, lungs are twice as likely to develop pulmonary embolisms. Lack of physical activity leads to hypertension, high blood pressure, sleep apnea, snoring, compression of spinal discs, herniated lumbar discs. The Washington Post reported sitting a lot also causes leg disorders, varicose veins, swollen ankles, deep vein thrombosis, muscle degeneration, hip pain, and worst of all, a limp, sagging rear end, because the glute muscles not only don't get used, circulation is cut off from the weight of the whole body pushing down on it. Medical News Today announced that our chairs are slowly but surely killing us. The links to all these studies are listed below this video. So what do? We have to work, right? Well, the first thing to have to look at, obviously, is our desk. It's actually becoming commonplace in many offices, factories, and even schools globally to switch to standing desks. They even have desks that instantly adjust from sitting to standing position and back down again as needed. Just Google standing desks and you get all kinds of companies. I myself use standing desks to do my video editing and even have a treadmill desk for doing my office work and online stuff. I find it's much more effective than the bicycle desk I have for working on the computer. Even though my legs are moving, you're still sitting, and the leg muscles are not supporting the weight of the body. And this is why being on our feet is so important and effective. The act of standing requires all kinds of muscles to keep us from falling over. Muscles all over our body are constantly adjusting, tightening, and loosening to keep us balanced, from our feet to our legs to our torso, arms, and neck. That's thousands of muscles, big ones, little ones, constantly working to keep us from falling over. And all this work requires energy, which of course comes from our food, and fat, which doesn't get used if we sit around all day. So do as much as what you normally do standing up if you can. And if you can't, stand up every half hour for 5 minutes. Even if you don't do much, just stand up. And if you really want to get things moving, do some squats. And I don't mean 3 or 5, I mean 20 or 30. Take the stairs instead of the elevator. Throw out the TV and do more yard work. Clean up the house more. Do more repairs. Go to the park, walk down the street, or just stand around. Anything. You are not designed to sit. You are designed to be upright. Half your body is legs. They are there for a reason. Use them. If you value your life, get off your ass.
Okay. That's like a cutting razor. So now let's dive in. Can I have the outline of the slide so that everybody could follow? As I said, please feel free to stop me and ask for any clarification. I'm not here to lecture anybody. I'm here to discuss what we've all been hearing before now, today. So what we are here to do with this is to make sure that everyone that attended this event lives here being a gospel spreader, an ambassador, an evangelist, whatever. But it starts with you as well. Most times actions are louder than words. So the outline is, first of all, why is this important? I won't dwell much on that. You already know why it's important. All the technical sessions, we are based on why this is important. Then understanding the role of communication in NCD prevention. How do we segment our audience? And then media platform analysis, the messaging, challenges in communicating communicating to combat NCDs, and strategies to empower change through communication, innovative ways to reach audience effectively, combating fake news, which is very important, and then success stories, smart collaborations with Federal Ministry of Health and Social Welfare and public health CSOs, and then call to action. So let's just dive in. I'll keep it as simple as possible and expect everyone, this is quite a large audience, which is exciting because it shows the importance that we are attached to this. And we are both victims and culprits in this, because during the tea break, I was moving around just looking like this being an NCD event. People were like, no, I don't want sugar, just give it to me. But I see people pouring sugar and all of that, but that's just a joke. So let's move on. Let's have slide 1. Overview of NCDs in Nigeria. This already, again, I won't spend much time because we already have all that data, right? But I could go in a bit, like give you the prevalence statistics for the leading causes of NCDs. Hypertension is 1, diabetes, stroke, cancers, chronic respiratory diseases, asthma, sickle cell, and all of that. And some of this, when you hear, you wonder, like when the professor from the Hematology Association of Nigeria was speaking, and you wonder, why do we still even have sickle cell as an issue? I mean, it's no more the time you feel a child has been born and dies, it says on Obanje, meanwhile, the child had died because of having born with sickle cell. But still, that's a work of communication and engaging the right partners and stakeholders to pass the message. So I will skim overview of NCDs in Nigeria and go to the next slide. Role of communication in doing this is very critical. How do we use communication as a tool to inform, educate, motivate, mobilize individuals and communities towards healthier behaviors, healthy diets, physical activity, tobacco use, and all? In the clip we played, you saw how the emphasis was on being active, not sitting down most of the time, beyond 1 hour, and walking around, getting up to, But the thing is, we all know the answers, but we are struggling with the question. And why do I say this? Most of the time, we are all pocket physicians. We already know everything that needs to be done. But the question, like, what do I really want to achieve with this? All information I've received is always where we found ourselves lacking. So, how do you raise awareness and education? How do you communicate in such a way that people begin to see NCDs as a correlate of lifestyle? That's one. How do you encourage behavior change so that it's not just about passing flyers, doing TV commercials, radio jingles, and all of that? How do you connect with people? We'll look at this more when we come to the audience disaggregation. Now, what can communication really do? Because just like people attending a church sermon, the pastor preaches, sweats, talks about sin, talks about fornication, for instance. As people are leaving the church, they are sending a text message to their boyfriends, girlfriends, are you home? Church just finished. So, do we just listen to understand, or do we listen to use the information? I think this is very key for NCDs because it's no more a case of people not knowing. It's simply a case of willful obstinacy. It's not ignorance, it's stubbornness. And people believing that one more shot of whiskey, tequila will not kill me. But I'm not here to preach. I'm just here for us to agree on how we can make a difference. So, how do you use communication to achieve all this? Let's go to the next slide. In segmenting the audience for this is where the rubber meets the road. Because when I listen to all the speakers, from Dr. Anyike to Professor Felicia Anoma to Professor Biageli, Mrs. Megan, the MPSCDA guy, all of that, it seems that we all know really what is at stake. How do you craft your message in a way that the urban population, urban dwellers, see reality for themselves and see something in it for that message? You can't do a one-size-cap-fits-all. No matter how nice this hat looks on my head, I believe, if I give it to Anyike now, it won't look the same on him, right? So, how do you approach your audience with a content, media content that they can consume? Then the issue of age groups, that's very key. Because when people talk about NCDs, most of the time we believe, oh, it's for people with bald hair like me or gray hair and all. But from every conversation here, we've seen that every age bracket is involved. So how do you do this? I guess my rep from the National Blood Transfusion Blood Commission. When you want to segment your audience, the Gen Zs and Gen Alpha and all the other generation monikers we have set up, how do you craft messages? And when you're developing messages, you don't just develop this message to throw into radio while you know many people don't listen or tune into the radio. So the next thing is socioeconomic class, and then gender considerations, and what I call gender blood lifestyles. Before, people believe that it's only men that drink, only men smoke, only men do, some sort of stuff. But this is a different era we are living in. If you go to Instagram, go to TikTok and all of that, you see a whole lot of content. Too many. But the thing is, people pick what they want. And even if as health authorities we are not saying anything, it doesn't stop people from manufacturing. We'll get to that when we get to the social media and fake news and conspiracy theories bit. But what is important is for us to tailor our messaging, asking ourselves how or what will success look like. If I hear a jingle about salt, as me, I cook and eat at home. So that generic message about how dangerous salt usage is, just like when you open here, you could literally see everything we've come to do here summarized in this. So if you're to design messages to reach segments of the population, how do you do that? We'll get to that when we get to some other slides. Let's have the next slide. Yeah. Okay. So choosing your media. As I said, radio has 80% rural audience, which is astounding because people, those of us that do community outreach, communication for development and all of that, it's easier to get a consultant to do a jingle, and we do a good report that we've done jingles on TV, on radio, and all of that. Now, digital media, traditional media, community engagement, town unions, mosques, churches, and local markets. And when I say media, I need to clarify something. I use media in the context of a channel. So everybody in this room is a medium. You may not be a mass media, of course, but you are a medium, a channel. When you go home and your wife, your brother, your sister, your family members ask you, oh, how was your meeting here today? I said they talked about NCDs. What did they say about it? That you should be careful in doing this. Could you communicate to someone asking you that you spent a whole day here today? What did you learn? In a way that the person will get one nugget of what you benefited from here that will effect a lifestyle change. That's a question for you to ask yourself. Now, why I put town unions, most of the stuff here we're already doing. We're already doing radio, we're already doing TV, print media, and all of that. But when it comes to innovative approaches, communication for development, how do you really connect with people? Everybody here has a church, a mosque, a pastor, and a imam that he or she listens to. So, I can remember, I'm not much of a church goer, but a few times I've been to church and all the sermons I read online, I've never heard a pastor or a reverend father talking about NCDs, like that's the topic of the sermon for that day. I don't know if anybody, do we have any FBO, faith-based leader here in this room? Which is a very sad miss. Because this is like inviting CNN to this meeting. If you have the GO of a church here that controls his own audience and they believe whatever he says as coming directly from God, and he says, you, my beloved brothers and sisters, it is not good for you to have, where is it? To have a salt shaker on your table. Many people in this room have salt shakers on their dining table. True or false? Someone somewhere here has that and uses it, forgetting everything that have been discussed here. Now, how do you begin to engage the people that really communicate everything we've said here in simple language that people will begin to see value for their lives in this? I think this is very important. Now, no, go back to that before you close. I'm talking about local markets. Why, how often does any of the partners or as a group go to taco market and talk about NCDs? That's very difficult, but it's very impactful. Remember, the title for what we are talking about is Empowering Change, Communicating to Combat NCDs. So this goes beyond just passing flyers, just convenient stuff of developing jingles and it being aired on radio. How much lifestyle change have those things caused? That's what we need to focus on. Engaging these three town unions, mosques, churches, and local markets alone can give us more impact than we can get at not as much cost as going to have a 6 months program, which is equally good, docudrama and all of that is good. But we are talking about those people who don't normally have access to DSTV, where some of this messaging are showed. But when you engage the people one-on-one, they ask you questions. If I tell somebody now, don't eat sugar, I say, why? Because sugar, yes, because diabetes, we are not diabetic in my family. I mean, it stops you short. But let's go on. So, let's go on to the next slide, please. How and when to message. Most of the things I've said are captured here. How do we make sure that I developed an acronym, CRICAX, which is have to make your message very clear, no medical jargons. Then 2, is it relevant to me? Can you take a message about do not eat mayonnaise and all of this to a village where people never heard of mayonnaise? Does it resonate? Now we have to make the message credible. Anyike and some of the other people that spoke in the last session talked about data. To fight conspiracy theory and fake news, you need data. And you don't wait for this data to be deployed when a counter information or false information has been released. So you educate people, let them know the importance of checking their vital signs, numbers, know your numbers, that's what they call it, right? So if people understand this normally, and again, remember, churches, mosques, I use this often because I've run campaigns on HIV/AIDS and all of that, and I know the role churches played scored more impact for us at the community level than what we could get from easily measurable, modes of communication like putting up survey and all of that. They are all good, but we are talking about looking at the demography of Nigeria. What will people take and believe? So if you give me data, I mean, we all in this room know how it is when you talk about vaccination, and Timoji here knows how difficult it is, or it was when we are doing the diphtheria vaccination, the HPV vaccine and all of that. Now, actionable, cultural sensitivity. It will be message dead on arrival if I go to a Muslim community and I start quoting the scriptures for them. Just to use that bare-faced example. Or go to a Gen Z and start telling him or her about something she or he believes is for older people like us. So I created what I call KISS boot steers. KISS is simple, like keep it simple, or keep it short and simple. Keep it smart and simple. That's the messaging. Let people know from everyday examples that NCDs are not something you meet way down the line in your growth. I've seen a 19-year-old being diagnosed with diabetes, type 2 diabetes, right? It happens. But if you had told that child that it will happen, he will tell you, well, I'm still a young man, I'm still a baby. That's what the Gen Z will tell you, I'm still a baby, Now, if just last 2 months, a colleague of mine in the office, her son called me that he was feeling very sad. I said, what happened? He said a friend of his, a 23-year-old boy, collapsed and died in Otako Market. Of course, if he had visited you or anybody, they would say you killed him. Right? Now, boot is like action. Reactivate. So when I say, this is actually a message for the younger generations, they understand this, KISS, boot, steers. Like, communicate this in a simple way, take action, and raise your steers. It resonates with them, And the whole idea is to keep the messaging very simple. Stay fit, stay strong, check your health, protect your family. Good health is wealth. Eat what you grow. Healthy moms, healthy families. This Eat What You Grow actually became a campaign in South Africa and some other European countries at some point. Because an oncologist, after a 25-year-old practice, he found out that many people were coming down with cancer and all the tumors based on eating processed foods. And this is very, very strange, because when you talk about this, people always think that eating and living healthy is for the middle and upper class, but it's not. In my neighbor's house, he has a steward, like a woman with child that cooks for him. And this woman is from Nasarawa, and she will say she won't eat yam, she won't eat potato, she would rather eat Indomie rice, because in her mind, these are food you eat when you are no more suffering. Right? Now, eating organic is a rave in Europe, but in Nigeria, poor people eat organic. Really, literally. And this is where our communication comes again. How do you begin to engage with people so that they will understand that a meal of potato, which is sweet potato, which is not as expensive as a loaf of bread, is actually healthier, does more good for your body than taking a loaf of bread and sharing and feeling like I've arrived. Now, let's go to the next slide. I'll move a little quickly. So, there are barriers in communicating how to combat NCDs and health literacy barriers. I will ask a question randomly. I want this to be interactive. So, sir, tell me, what is health literacy? You can take the mic so we can hear you. This is very important. Please pay attention, because when we talk about this, people always feel, I know it's for people. So tell us, sir.
It's for someone to know the dietary needs that she wants and anything that is associated to what he is consumed to be healthy. Okay. Thank you.
All right. Thank you. Who else wants to try? Just one more person. Else I'll choose a lady. Madam? Hello, madam. Can you tell us what we mean by health literacy? Can you give her the mic? Okay, let me give you the mic. I really want, because this is very important. Yeah, here, madam. Hello?
Oh, was it me?
Yes, of course. Oh, really? I know you know the answer, so just to make it easy. Yeah. Just tell us what health literacy means.
It's about creating awareness and educating the populace.
No, you. What it means to you.
Oh, yes. How informed?
If I ask now, are all of us in this room health literate? The answer will be a resonating yes. So, what does it mean to you as an individual?
Yeah, how informed and aware I am about issues concerning my own health. And what's happening out there and how it impacts on me and the decisions that I make and choices that I make regarding my health.
Okay. Why do people look for information?
Yeah, to make decisions. You want to know what it is about. And change certain behaviors where necessary and take action, yeah.
Exactly. See, I knew you knew it. So, now, let's see. Can you throw down what health literacy means? Good. So, is an ability to obtain, read, understand, and in caps, use health information and make appropriate decisions. So, many of us here will go home today with enough information. We've obtained it. Perhaps 20% may read it. Then maybe 15 out of that 20, hopefully, will understand it. And then is in using it. And again, being a typical Nigerian, I will also go to religion. Everybody in this room, Christian, Muslim, has a Bible or a Quran. Yes? Exactly. If Allah or God walks into this room and said, I'm gonna judge just what you've done in your mind, everything since this program started, all of us will end up in hell. Including me, yes. So, the Bible says the truth you know and do will set you free. So, and this is very, very important, because if you have all this information, let's go to the next slide so I can move a little bit quickly. If we have all this information and we don't use them, it's of no use. Anike said we have a lot of policies, a lot of everything. Is that paper is for me, right? Yeah. Yeah. So if we don't take action by ourselves and encourage others to take action, the whole thing is done. So we are working with sector-wide approaches. That's the basis of Nigeria Health Sector Renewal Investment Initiative. And that is built on collaborations, and this is the only way we can really make a change, by bringing a whole of government and a whole of society approach. So, multi-sector collaboration, leveraging technology and digital media, and community-based approach, which I had mentioned earlier when I spoke about engaging community leaders, faith-based organizations, and all the other partners. Let's go to the next slide. Now, innovative ways to do this: mobile health, social media influencers, community engagement again, gamification, and 5. The 1 to 4 we're already doing. Let me just spend 2 minutes on restaurants and food vendors, because many people in urban centers eat out, and it's actually something people love doing. So how do we, it's more difficult to begin to control people going to buy if we don't get to the source. How much engagement have we had with food vendors and restaurants? Let's be honest. We go for meetings like here. If you go to that, like breakfast in Hilton, Sheraton, and you want pap, they tell you they don't have pap. They have custard. Okay? Many restaurants like that. So how do we take the messaging to people that do small chops? How do we tell them, don't use as much sugar? And then not just telling them, we set up a framework where they will be recognized. Tell them what is in it for them. Why wouldn't a restaurant advertise beyond these foods and stress that we have healthy menu options? There are practical things that are suitable for our own culture and, lifestyle. Let's go to the next one. Fake news. Everybody in this room knows about it, but let's quickly talk about how to combat it. Before I move to the other side, let me just talk briefly about the cultural, religious, and superstitious beliefs surrounding fake news. And again, its credibility, its relevance is getting to the people that people believe. During COVID, we heard or saw a lot of religious leaders taking up platforms to say, don't take COVID vaccine and all of that. HPV, as recently as last year, we saw that as well. So being proactive, when you have a lifestyle changing program, do you take it to people as you are bringing it to them? How do you engage? How do you get people to own this messaging and give it to their people? Because there's always that suspicion, like you people coming from the government have your ulterior motives. Now, how do you sit down and engage traditional leaders, town hall presidents, town union presidents, and all of that? Now, media partnerships, information, education, communication palace, building relationships, skits, and counter skits. I've seen a whole lot. Just this morning or last night, I deleted my Instagram and TikTok. Why? There's so much. Everybody now is an expert. But you won't run away from it. How do you begin to develop, seeing all that, to make sure that they don't have the last word? And not just saying it on social media, taking what they've said to meet with people that have the credibility to cause a lifestyle and mindset change. Now, community engagement initiatives, community leaders have mentioned FBO to spread health literacy. Let's go to the next slide. Now, success stories. This is basically what we have here in the publications. Tobacco control in Senegal, it became a national program because maybe the Senegalese smoke more than most West African countries, and they took it upon themselves to begin to lecture people and get even the various drinking places, joints, to tell people, before you smoke, have you reasoned ABCD? We had the salt reduction campaign in Ghana. We had the Côte d'Ivoire Community Health Work Program. Again, I'm glad the MPCADA guy dwelt on the role of community health workers and using the primary health care centers. Just recently, the Coordinating Minister of Health and Social Welfare, they launched the groundbreaking for 10 oncological centers in Bauchi, which will be replicated in all the 6 geopolitical zones. But the question is, how do we make sure that this is not a one-time off thing? Now, let's go to the next slide, please. Smart collaborations with Federal Ministry of Health and Social Welfare, parastatals, and CSOs. We have to focus on one thing: advocacy awareness, monitoring and evaluation, and community engagement. Every other thing here, we know why NIPRID is there, is that there's always a particular stakeholder we don't go to most of the time, and these are the traditional, or unorthodox medical practitioners, the Babalawos, the DBS, and all of them. These are the people that the first recourse, someone feels his temperature, he goes to the traditional healer to do something, then go to his pastor and religious leaders. Let's go to the next one. So, we done? So, the success of the national NCDs policy documents launched today will require a Commission for Development approach to foster strong, smart collaborations with key stakeholders, and effective communication and smart collaborations are catalysts for change in the fight we have taken up on ourselves. And the successes we are seeing in SWAP is actually a pure catalyst for this, because no organization can go at this alone. Hence, we have all these wonderful NGOs and agencies and government agencies listed. So, what will success look like? One, increased awareness and knowledge, the NCD lifestyle connection, behavioral change. Do we have a noticeable shift in that? Policy support and implementation, active engagement of key stakeholders, FBOs, I've listed all this before, then improve outcomes. How do we now know that what we are doing is working? Because we need to always benchmark what we've done, what we've achieved, so that it will inform our ongoing effort to combat this. Thank you so much. So I don't know if anybody has any question. Meanwhile, if you look at your folder, you will see a paper on this presentation, a well-elaborated paper. So why we put this is that, as I said, this was not a technical presentation. It's to arm people to go home and make a difference to your co-workers and all. So if you go through this, you will get more, granular details about the presentation. Thank you again, and if there's any question, you can always approach me during lunch. Thank you. Sister Moji.
Thank you very much. Can we please appreciate him one more time? Thank you. So we would now have vote of thanks, which should be like 2 minutes. I'd like to call on Dr. Ozi, who is going to give the vote of thanks, and to also keep Dr. Eze Sunday on notice for him to also give us any other information. Thank you very much, sir. Wow.
Thank you. Good afternoon, ladies and gentlemen. Well, looking at the calibers of people I have in this hall, I think I'm highly delighted and happy, because this is a success for non-communicable diseases in our country. So on this note, in no particular order, but I have to follow the protocol to humbly and respectfully appreciate and thank our Honorable Minister for Health and Social Welfare, ably being represented by our Permanent Secretary, for having time to be with us in spite of her tight schedule. So we want to appreciate her for coming. Our Permanent Secretary, too, ably represented by Dr. Chukuma Ainke, who happens to be my Director of Public Health, we want to appreciate your attendance. Thank you so much for coming. The Honorable Commissioners here present, we want to say a big thank you for honoring our invitations. In your various states, you will champion this cause for us, and that is what is expected of you to do for us. So we are looking up to you to do this task for us. Chairman Natop, who happens to be our director too, we want to thank you for coming. We quite appreciate your contributions. In fact, for the last 3 days, you have been with us. So there is nothing we can say rather than thanking you for attending all our meetings. Representatives of our MDAs here, I want to appreciate all your contributions and commitment to fight NCDs in Nigeria. WHO, you came in full force. Yes, full force in the sense that there are representatives from the headquarters, that is WHO headquarters. There are representatives from African region, and there are representatives from Nigeria. So we quite appreciate you. We quite appreciate your support, both technically and financially. So thank you so much for always being with us. My dear directors of public health from the states, this is a challenge for us, but we have started, and by God's grace, we shall win. So I don't have much to say to you people, but just to thank you for honoring our invitation. The journey has just started. We still have a long way to go, but in as much as that, I want to appreciate your coming and thank you also for attending our meetings. To our partners, in fact, I didn't just want to name them, but we have few here. We have Resolve to Save Life. We have Project Hope. We have Population Service International, that is PSI. We have MHH. We have Nigerian Tobacco Alliance, and we have NCD Alliance. These organizations and partners have really contributed to the success of this meeting. In fact, without them, we will not be where we are today. So we really appreciate your efforts, and please let these contributions continue to be something that will forge ahead and improve upon. Thank you so much for being with us. Other NGOs here present will recognize your presence. I want to thank you all for being with us. The people living with NCDs, this is a challenge to us all. You can be our ambassadors wherever you are. So we appreciate your efforts. This is just a little we can deliver for now, but we have much more to give. But when the time comes, and with continuous collaboration, we will be where we want to be. Thank you so much for coming. Ladies and gentlemen of the press, today is not just a day that we just want to showcase here. Please, we want you to give this event a wider publication. Let the world know what we are doing in NCD space in our country. Let them know what the challenges are. And let us know, and let them know how people can get information and also use this information for the benefits of those with NCDs. Thank you for coming. And our able uncle, I used to say Mama Moji, thank you for being with us. We are very grateful for your coming and contributing to the success of this event. And it is on this note that I want to say a very big thank you to us. My secretariat, thank you so much for the support you have been giving. If I've left anybody without mentioning, please, the opportunity will not allow us to mention each and every one of us, but your contributions to the success of this meeting Oh, the executive secretaries. Thank you so much. The executive secretaries of primary healthcare centers. Your role cannot be overemphasized, but we recognize you, and we want to thank you also for coming and supporting us in this fight. You know, at the federal level, we are cooperating with National Primary Healthcare Development Agency, and that is what we want you people to replicate at the state level too. So thank you so much for coming. We are very grateful for your attendance. So on this note, I just want to wish us all the safest journey back to our various destinations. Thank you so much.
Thank you very much. A couple of announcements before we take the national anthem. For lunch, the ballroom 1 is where is where the masses will go. Okay. But for our commissioners, chairpersons, permanent secretaries, and our ES from the states, and WHO, of course. Well, did I hear the appreciation for WHO? Okay, all right. Yes, and would be at Obudu Grill. Yes, and I'm sure there'll be somebody there too. Yes, the ushers would direct us to that place. Yeah. Okay. Emeka, don't go too far. Yes, a post, you can see on the screen, your feedback matters. Please take our post-event survey to help us improve future events. You can use your smartphones, to get this, and please, the feedback is important because NCDC conversation will continue from here. Any other, well, non-communicable diseases. When you have these MDAs all in your head, there's the possibility to mix it up. But seriously, that's where we go. Are the IT people ready for the national anthem? We'll take the national anthem, we'll have lunch, and I do pray that you have a good time in Abuja, devoid of non-communicable diseases. But for those, for those who have it, you can manage it. It's a lifestyle thing. Well, thank you very much for giving me the opportunity to anchor this. I pray that what we have launched today will springboard into implementation. Shall we please all rise for the national anthem?
Nigeria, we hail thee, our own dear native land. Though tribe and tongue may differ, in brotherhood we stand. Nigerians all and proud to serve our sovereign motherland. Our flag shall be a symbol that truth and justice reign. In peace or battle honored, and this we count as gain. To hang on to our children a banner without stain. O God of all creation, grant
Have a good day.